MEDIC-MRCOG, and a very warm welcome to all of you as we begin our 10-day CRISP revision course in our endeavor to help you to clear the Part-2 MRCOG exam. And we have Dr. Soumya here with us as well today. So before we begin, I would request Dr. Soumya to say a few words to you, and then we will go ahead with the session.
Hi Chitra, good evening. Thank you so much. Yes, guys, thank you so much for joining for this revision marathon series. This is one such program which we have thought of to help you all to get these concepts clarified. As I have said it multiple times, again, this is going to be a crisp revision of the modules or the concepts which you are going to get in the exam. So to make sure to keep the timeline, what we have done is you can actually ask the questions in the chat box. Of course, that would directly go to Chitra and the host. So probably if we are not able to answer right away, it would be given to you all these answers. What I'm thinking is to compile these questions probably into a mock and give it towards the end of this. But please make sure that you guys attend this live because it's very important. In 3 hours, actually for maternal medicine, we have dedicated 2 days, that is 6 hours for maternal medicine because it's a huge one. And there's a lot of effort of every single person, whoever has been part of this, from backend team to the mentors, so that you would be getting the beautiful presentations and you would be able to gather the concept. Okay, we have adjusted the slides in such a way that this is very much visually attractive and you will have an impacting memory. Okay, so Chitra, thank you so much. And guys, I hope you would all enjoy this. Make sure to learn this because this is extremely important. I've been getting a messages, how do I revise this in the next 4 weeks? This 10 days, if you attend, you're going to revise the whole syllabus with us. Hope to see all of you enjoying these sessions and don't forget to drop the feedback towards the end. Chitra, over to you because I didn't want to take more than 2 minutes because I know how much it is there. Thank you, darling. Thank you so much.
All right. Thank you so much, Dr. Soumya. So let us begin. And as Dr. Soumya said, maternal medicine we have divided for 2 days because maternal medicine is really very huge. And I'm sure all of you are going to remain muted. If any doubts, just put them up in the chat box and we would find some way to address those doubts for you. So for today, we have three main topics: hypertensive disorders, thrombosis and antiphospholipid syndrome, and metabolic and endocrine disorders. So for you, for hypertensive disorders, you have the NICE guideline and the International Society for Prevention of Hypertension. These are the two main reference points for this. So in hypertension, you should be knowing all the definitions of the various hypertensive disorders in pregnancy, the pathophysiology of preeclampsia, what is the risk stratification, who all deserves or should be given aspirin, then what is Pierce and SFLT? What is the significance of these two? The antihypertensives, which are safe in pregnancy. What is the role of magnesium sulfate in eclampsia? What is HELLP? How do you manage fluid management for patients or women, those who have preeclampsia? Timing of birth, which is something very important. And then postpartum hypertension, the long-term consequences that would happen in women, those who have preeclampsia, and about breast. So you have to know all these things in hypertensive disorders. Then in thrombosis and antiphospholipid syndrome, again, you have the green top guidelines. And that is the main reference point for this. So you should be knowing how pregnancy is a hypercoagulable state and how do you score women, or how do you stratify who is at a higher risk of developing venous thromboembolism in pregnancy, the role of low molecular weight heparin, management of acute venous thromboembolism and pulmonary embolism. How do you diagnose antiphospholipid syndrome? What is CAPS? Then the role of anticoagulants in women, those who have mechanical valves, cardiac valves. What about warfarin or the oral anticoagulative agents? What is HIT? Then women, those who are on low molecular weight heparin, when do you stop it prior to giving them some regional anesthetic, and when do you start it again after the regional anesthetic? Do we have any antidotes for low molecular weight heparin and for unfractionated heparin? And then what is the role of low molecular weight heparin in women those who have recurrent miscarriage? In metabolic and endocrine, most important is diabetes. So pre-existing diabetes and GDM. What is the role of HbA1c? What about continuous glucose monitoring in women, those who have diabetes? How do you diagnose GDM? What are the indications for screening? How do you do the oral glucose tolerance test? What is the management of women, those who have GDM? Antepartum, intrapartum, postpartum. And in endocrine, most important is thyroid. It is a very hot topic of the college. So you have to be aware of everything for that, especially the drugs that would be safe in pregnancy and in breastfeeding. What about postpartum thyroiditis? And not to forget, women, those who have obesity and those who have undergone bariatric surgery. Okay, so these are the main topics that we would be discussing today. Now, the most important thing that you have to remember, especially from an exam point of view, is that remember low dose aspirin, 75 to 150 milligrams. Nowadays, low dose aspirin is considered to be 150 milligrams. So you have to start it from 12 weeks of pregnancy. For women, those who have at least one high risk factor, those who have two or more than two moderate risk factors. Okay. And remember that the scoring for venous thromboembolism, you will do it at booking. If the pregnant lady is admitted at any time in the interpartum period or the postpartum period, and even in the postpartum period, you will again do the risk scoring. Okay. The important thing to remember is that in the antenatal period, if her score is 3 or more than 3, you will start for her low molecular weight heparin from 28 weeks of pregnancy. If it is 4 or more, start it from the first trimester. Please remember this. Now for GDM, don't forget the magic numbers 5, 6, 7, 8. Okay, I'm sure all of you know this. And remember that even one abnormal value qualifies to name the woman as having GDM. It is not necessary that both the values should be abnormal. So this is actually the weightage that each of the topics has based on the recalls that we have had from the previous years. But I would say that please give equal weightage to all of them, because if you say that, okay, I am not going to read something about GDM postnatal screening, and you have a lot of questions in the exam, okay, so you would be losing a lot of points. So make sure that you do not skip any topics. Each topic has to be done thoroughly. Now, first, let us start with hypertensive disorders. You have to be aware of the definitions. Remember, chronic hypertension, any woman who comes to the booking clinic and she has pre-existing hypertension, she is on any antihypertensive drug, or before 20 weeks of pregnancy, her blood pressure is more than or equal to 140/90. She qualifies as chronic hypertension. Remember, for this, women those who are already on antihypertensives, when they present to you at booking or early pregnancy, remember that ACE inhibitors and angiotensin receptor blockers are not safe in pregnancy. You have to change them within 2 days of the pregnancy test being positive, or if they come to you in the preconceptional clinic, at that time itself, you can change the drugs. In gestational hypertension, the most important thing is that there is no proteinuria. So new onset blood pressure after 20 weeks of pregnancy with no proteinuria, it becomes gestational hypertension. But even then, here it is important to monitor these women, because 15 to 25% of them do progress on to becoming preeclampsia. Now, preeclampsia, as we know, hypertension after 20 weeks of pregnancy with proteinuria, or there could be organ dysfunction, or there could be uteroplacental dysfunction. The key feature one you have to remember is that high blood pressure, that means hypertension with proteinuria. So if you are doing a protein creatinine ratio and it is more than or equal to 30 milligram per millimole, or albumin creatinine ratio of more than or equal to 8 milligram per millimole, that is sufficient to diagnose preeclampsia. Of course, we do not do 24-hour proteins anymore, urinary proteins, but if it is more than or equal to 1 gram, then also it is said to be significant proteinuria to diagnose the woman as preeclampsia. Now, what is severe preeclampsia? So here, the blood pressure has to be more than or equal to 160 by 110. And she could be having signs and symptoms like headache, nausea, vomiting, edema, visual symptoms like scotomata, or she could be having biochemical and hematological changes. It's very important to diagnose these women immediately because it's important to control the blood pressure immediately. And if they are not responding to the antihypertensive agents, you should be considering birth for them. Eclampsia is any woman who has preeclampsia and she has new onset tonic-clonic seizures. Remember, eclampsia doesn't happen only in the antepartum period. According to Embrace, 44% occurs in the postpartum period. So please remember to monitor your preeclampsia patients in the postpartum period as well. HELLP. So it's very easy. Hemolysis, elevated liver enzymes, and low platelet counts. So thrombocytopenia, where platelet counts are less than 100. It's nothing, but it's a variant of severe preeclampsia. And what is PRES? So that is posterior reversible encephalopathy syndrome. This is confirmed by MRI. Any woman with preeclampsia, with headache, visual loss, or seizures, not responding to your routine antihypertensive treatment, think of PRES, do an MRI, it will confirm the diagnosis. Now, there is another entity called as superimposed preeclampsia. So, women, those who have chronic hypertension and they develop either proteinuria or organ dysfunction after 20 weeks of pregnancy, you will rename them as chronic hypertension with superimposed preeclampsia. Now, before we see what is the management, let us see what is the pathophysiology, because then you would be able to understand why it is important to start aspirin from 12 weeks of pregnancy. So there are basically two stages of this preeclampsia pathophysiology. Stage 1 is the placental phase. We all know that during pregnancy, the spiral arteries, they are invaded by the trophoblast and there is a remodeling of these spiral arteries. They become more distensible. But in women, those who are going to develop preeclampsia, this remodeling of the spiral artery doesn't take place. And that leads to placental ischemia. Now, this phase 1 or stage 1, it is usually completed by about 16 weeks of pregnancy. And if you start aspirin after 16 weeks of pregnancy, this phase is already complete. So it doesn't make sense to give aspirin after that. It's not going to help. So women, those who are at a high risk of developing preeclampsia, for them, aspirin, to get the maximum benefit, you have to start from 12 weeks of pregnancy. Now, stage 2. This is the maternal phase. So what happens here is that anti-angiogenic factors like SFLT1 or soluble endoglin, these factors increase, and placental-like growth factor or vascular endothelial growth factor, these factors decrease. So there is endothelial dysfunction, and this leads, so basically why we are interested in doing the SFLT to placental-like growth factor ratio. Because if this ratio is distorted, that means if this ratio is increased, then you can predict that this woman is likely to develop preeclampsia. Please remember, this is not for diagnosis. The SFLT to placental-like growth factor ratio, it is basically to predict. So whenever the ratio is low, that means it is less than 38, it is very unlikely that this woman will develop preeclampsia in the upcoming 1 to 1.5 weeks. Whereas if the ratio is high, specifically like more than 38 to up to 110, it is a high risk and this woman is very likely to develop preeclampsia in the upcoming 1 to 1.5 weeks. So then she needs admission and you would have to make decisions accordingly. Now, when is this ratio done? It is done between 24 to 36 plus 6 weeks of pregnancy. Again, I would like to emphasize that this is not for diagnosis, it is only to predict whether this woman is likely to develop preeclampsia or not. Okay. Okay, let's come back to the pathophysiology. So now, because of all the endothelial dysfunctioning that is happening, what happens is you start getting the end organ defects. There is vasospasm, there is microthrombi, there is capillary leak. So because of the vasospasm, you get a increase in the blood pressure. That means the blood pressure rises. Because of the microthrombi and capillary leak, especially whatever is happening in the kidneys, you start getting proteinuria. Microthrombi in the placenta, they will give rise to fetal growth restriction. Again, because of the damage that is happening to the kidneys, you can get oliguria. The microthrombi and all these things, they will give rise to HELLP and PRESS. Okay. So how do you help this woman to recover from all this pathophysiology? The only thing is you have to remove the trigger. The trigger for all this is the placenta. So that is why we say that birth is the only definitive treatment for women, those who have preeclampsia. Whatever antihypertensives you are giving, max sulf you are giving, all this is basically only symptomatic treatment. The woman is going to recover only once the placenta is removed. Okay. So the cascade that is there for preeclampsia, it all begins with faulty placentation. You get a rise in the SFLT, decrease in the placental-like growth factor. That leads to endothelial dysfunction. There is hypertension, multi-organ injury, and delivery or removal of the placenta is the only cure, or that is the definitive treatment for these women. Now coming to aspirin. So low dose aspirin. Are you going to give aspirin to every woman that is pregnant? No. There are high risk factors and there are moderate risk factors. So more than one or more than one high risk factor. Hypertensive disease in a previous pregnancy, chronic kidney disease, autoimmune diseases like SLE or APS, type 1 or type 2 diabetes, and chronic hypertension. Even if one high risk factor is present, start aspirin from 12 weeks of pregnancy. Moderate risk factors, more than or equal to 2. So first pregnancy, age more than or equal to 40 years, pregnancy interval of more than 10 years, BMI more than 35 at first visit. Please remember, at first visit. Family history of preeclampsia, not family history of hypertensive disorders. And multifetal pregnancy. Any 2 or more than 2, start aspirin from 12 weeks of pregnancy. Low dose aspirin. Okay. Please remember, the benefit of aspirin is lost if it is started after 16 weeks. How long do you give aspirin? Some protocols say continue aspirin till the woman delivers. Some of them say stop at 36 weeks of pregnancy. And another thing to remember is that aspirin does not completely reduce the risk of developing preeclampsia. It reduces the risk by 10 to 20%. A few traps that are there with aspirin, which are important from your exam point of view. Whenever there is only one moderate risk factor, no aspirin. Okay. If the woman only has a twin pregnancy, it's a multifetal pregnancy. So that is a moderate risk factor. That is one risk factor. She must have another moderate risk factor. So like if she is a primey and she has a multifetal pregnancy, then she qualifies for aspirin. But only a twin pregnancy in a woman who is a multipara, she doesn't qualify for aspirin. And remember, aspirin, it is not an antihypertensive, nor does it replace low molecular weight heparin. Please remember this, very important. Now coming to the diagnosis of preeclampsia. How do you diagnose? So remember that you should have a blood pressure elevation at or after 20 weeks of pregnancy. So if the blood pressure is more than or equal to 140/90 at 20 weeks of pregnancy, you will look out for proteinuria. We've already seen what is the significant levels. Does she have proteinuria or she doesn't have proteinuria? If there is no proteinuria, check for other organ dysfunction. So look at her creatinine, platelets, liver function tests, look at her any neurological signs and symptoms, and also do a fetal Doppler. On the other hand, if there is proteinuria, it is confirmed that she is preeclampsia. So if she has organ dysfunction, again, it is preeclampsia. If there is no organ dysfunction, she only has hypertension and no proteinuria. Then it becomes gestational hypertension. Okay. Now, any woman for whom preeclampsia is confirmed, you will assess her severity. So check her blood pressure, see whether if the blood pressure is more than or equal to 160 by 110, that means it becomes severe preeclampsia. Look out for signs and symptoms and also try to find out if she has any biochemical disorders there. Okay, so this is the flow chart on how you're going to diagnose preeclampsia. The next is blood pressure measurement, how you're going to monitor these women with preeclampsia, and what about blood pressure reading at home. So remember the cuff size. Do not use very small cuffs or very large cuffs, because for an obese woman, if you use a very small cuff, you are going to get wrong readings, especially for very thin-built women. If you use a cuff that is meant for women with high BMI, again, your readings are going to be wrong. The bladder of the blood pressure cuff, it should encircle 80% of arm circumference. Now, what is the position? Please do not measure blood pressure in the standing position or in the lying down position. The woman should be seated. Her back should be supported, her feet placed flat on the ground. The arm should be at the level of the heart, and you should not measure her blood pressure immediately the minute she walks into your clinic. Let her rest for 5 minutes. After that, get a blood pressure reading. Now, what about the Korotkov's sounds? We know there are 5 sounds. So normally in pregnancy, we use disappearance of phase 5. But if phase 5 is absent, even you could use phase 4 for measuring the blood pressure. Always use standard devices. And women, those who have been diagnosed with chronic hypertension or gestational hypertension, ask them to record their blood pressure at home. The record has to be done at least twice daily, morning and evening. Now, what about ambulatory blood pressure? So it is basically for anyone who has white coat hypertension. So you will always consider before labeling any woman with hypertension. Okay, consider white coat hypertension. Now, women, those who have severe hypertension, if you have a blood pressure reading of more than or 160 by 110, please confirm it within 15 minutes. And this woman, she qualifies for urgent treatment, immediately admission and antihypertensives and the rest of the management. Do not leave any woman with severe hypertension unattended. Okay. A few things that you have to remember, that blood pressure is highest because the physiological variations that happen during pregnancy. Blood pressure is highest at 32 to 34 weeks of pregnancy. It normally mid-pregnancy, we expect a fall in the blood pressure in second trimester, and then at third trimester, it again starts rising. Women, those who have white coat hypertension, about 50% of them progress to gestational hypertension. So these women, again, before labeling her as white coat hypertension, make sure that she is being monitored adequately. Okay, now coming to antihypertensive drugs. It's very important because the drugs that you are offering to these women, they have to be pregnancy safe. Not only in the antenatal period, intrapartum, and during breastfeeding also, if she's going to need it in the postpartum period. So the first line drug is labetalol, that is recommended by NICE guidelines now. Remember, it is a combined, or it's a non-specific alpha and beta blocker. It is first line oral and also first line intravenously for women with severe hypertension. It is safe in pregnancy. Only thing, remember, avoid labetalol in any woman who has asthma. It is safe in breastfeeding also. Now, nifedipine, which is a calcium channel blocker, it is second line drug. You can use it if labetalol is contraindicated, like allergy or not available or anything. But one thing to remember with nifedipine, it is contraindicated in any woman who has any cardiac disease, like congenital cardiac disease, or she has had AMI in the last 1 month. So for these women, any cardiac issues that are there, please avoid nifedipine. Again, nifedipine is safe in pregnancy and in breastfeeding. Methyl dopa, which is a central alpha agonist, it is now third line. It is safe in pregnancy, but in the postpartum period, remember, you will stop it within 48 hours of birth. So in breastfeeding, obviously, we are not going to use it in the postpartum period. So we do not use it in breastfeeding mothers. Now, hydralazine specifically limited to treatment of severe hypertension. It is given intravenously. It is both an arterial and a venodilator. So the drop in blood pressure is very sudden. Remember, before giving hydralazine, make sure that the woman is well hydrated. It is recommended only for acute use, not long-term use in pregnancy. It is safe even in women those who are breastfeeding. Now, doxazocin, which is an alpha blocker, it is used with caution in pregnancy, only after input from a specialist. It is safe in breastfeeding also. ACE inhibitors, ARBs, and diuretics, you will normally avoid them in pregnancy. Okay, ACE inhibitors you will avoid because they cause renal dysgenesis and oligohydramnios in the developing fetus. But remember that enalapril and captopril, they are safe in the postpartum period or during breastfeeding also. ARBs also, you will avoid them in pregnancy because they can cause fetal renal injury. In the postpartum period, if you have a better alternative, use those drugs. If the woman is not responding to any other antihypertensive, then you could be using ARBs with caution. Diuretics, not used during pregnancy. And also, they are, as far as possible, avoided in breastfeeding because they could pass on through the breast milk to the fetus, and some of them also suppress lactation. Now, coming to the management of acute hypertension, severe hypertension in pregnancy. Whenever you have, remember, it is an obstetric emergency. Whenever you have any woman where the blood pressure is confirmed, it is more than 160 by 110 millimeters of mercury, immediately you will get an IV access. Do basic investigations like the full blood count, use NEs, liver function tests, urate, coagulation profile, urine PCR, and if she is in the antenatal period, also get a CTG done because you are also not only looking after the mother, you're looking after the baby as well. Find out whether she is already on any oral antihypertensive agents. If she is, then find out if she has taken her dose. Optimize that oral dose first. If not, the first line that you will give for her is IV labetalol if she is not responding to your oral antihypertensive. If the woman is not on any oral antihypertensive, again, IV labetalol is the first line drug that you would be using. You will be giving it in an IV infusion, 20. First, you will give 20 milligrams. If there is no response, you can escalate to 40 and 80. You can increase the dose every 10 minutes. Okay. If she is still not responding to IV labetalol, you can start hydralazine, 5 milligrams, slowly over 5 to 15 minutes. But remember, you will preload the woman whenever you are giving hydralazine or otherwise there is a sudden drop in the blood pressure and that can give rise to fetal heart changes. So please be careful when you are giving hydralazine. Now, the target blood pressure for any woman who has severe hypertension, within 1 hour, the blood pressure has to come down below 150 by 100. And these women, you will always keep on continuous electronic fetal monitoring because you are interested in the fetus also. And if she has signs and symptoms of severe preeclampsia, please do not forget to give magnesium sulfate. Why we are so interested in this hypertensive disorders is because Embrace says that ICH is the leading direct cause of maternal death. So we have to avoid intracranial hemorrhage at any cost. Now coming to magnesium sulfate. Though it is a very useful drug, sometimes it can be very dangerous. It has to be given under close monitoring, and you should also be aware of the dose. So magnesium sulfate, we give it as treatment for anyone who has developed eclampsia, or you can also give it as a prophylactic agent. Any woman who has severe preeclampsia, signs and symptoms of impending eclampsia, you will start magnesium sulfate for her. The loading dose is 4 grams intravenously, slowly in an IV infusion over 5 to 10 minutes. And the maintenance dose is 1 gram per hour in an IV infusion. How long will you continue this magnesium sulfate? You will continue it for 24 hours after birth or for 24 hours after the last seizure, whichever is later. Okay. And if in spite of your maintenance regime, if the woman, she has another fit, eclamptic fit, you could give another dose of magnesium sulfate, 2 to 4 grams intravenously over 5 minutes. If it still persists, you could give her diazepam. Now, monitoring of these women is very important. So you will be monitoring her respiratory rate, because we know respiratory depression is a very common side effect if magnesium sulfate is not given under close monitoring. You will monitor her deep tendon reflexes, urine output, then her oxygen saturation every 15 minutes initially, at least for 1 hour. And then it could be done every hour. The target serum magnesium levels are 2 to 3.5, though we are not doing it very routinely. The antidote that is there for magnesium sulfate, remember the rule of 10, okay, very easy to remember, 10 ml of 10% calcium gluconate over 10 minutes. Any woman who has renal impairment, for them you can reduce the maintenance dose to 0.5 grams. Instead of 1 gram 1 hourly, you can give 0.5 grams every hourly, especially if the creatinine is more than 90 or urine output is less than 20 ml per hour. Now, what is the toxicity ladder, magnesium toxicity ladder? So remember that because this drug is protein bound, there is a very narrow margin between what is the therapeutic dose and where it can lead to toxicity. So if the serum magnesium level is between 2 to 3.5, remember it is what we are aiming at, and you can continue the infusion. Now, if it increases to 3.5 to 5, the woman, she can start getting some signs and symptoms like nausea, warmth, or flushing. You have to monitor her very closely, and this is the time when you would want to check her magnesium levels again. If it increases 5 to 6, the first sign that will go is your patellar reflex will no longer be there. So when you're monitoring these women on magnesium sulfate, remember, if the patellar reflex is lost, please escalate immediately and stop the infusion and check magnesium levels. It doesn't make sense that the patellar reflex is lost, the infusion is continuing, and you are asking for magnesium levels. If there is no patellar reflex, stop the infusion of magnesium sulfate and immediately ask for magnesium levels. If it is increased to 6 to 7, then there is respiratory depression. So normally any woman who is on a magnesium sulfate infusion, we are looking at the respiratory rate. It has to be a minimum of 16 per minute. Respiratory depression, we label it if the rate is less than 12. So here also, stop the infusion immediately and give her calcium gluconate. If it is more than 7, this is the danger zone. It leads to cardiac arrest. So stop the infusion, start CPR, give calcium gluconate, and intubate. Okay. So this is the magnesium toxicity ladder. Important thing to remember here is that Once the patellar reflex is lost, please stop the infusion immediately. Okay? And remember the rule of 10 for giving calcium gluconate. Now, management of eclampsia. So the first 30 minutes are really very crucial. How do you resuscitate any woman? So please don't forget A, B, C, D, E. Give magnesium sulfate and plan her delivery. So airway. You will put her in the left lateral or in the recovery position. You will do suction for her if needed, give a jaw thrust, and make sure that the airway is open. For breathing, you will start oxygen 15 liters per minute via a non-rebreather, and you will also start pulse oximetry for her to know her oxygen saturation. To maintain her circulation, two wide bore cannulas have to be put in. Get all the basic investigations done. Look for any disabilities. So, time the seizure accurately. If the seizure is lasting for more than 5 minutes, normally these eclamptic seizures, they do not last. They last for about, say, 40 to 45 seconds. If someone is having a seizure for more than 5 minutes, you will give her diazepam immediately. And exposure. So once the seizure has stopped, examine her for trauma, like tongue bite is something which is very common. Also, don't forget that this woman is pregnant, so put on a CTG, make sure that the fetus is doing well, and if needed, you could do a vaginal examination to assess the cervix. Once the woman has been resuscitated, start magnesium sulfate immediately according to the protocol. So 4 grams intravenously and then 1 gram infusion. To control her blood pressure, remember, it is not enough only giving her magnesium sulfate. The basic pathology is her high blood pressure. So she needs antihypertensive agents. So labetalol or hydralazine as per the clinical picture. And then you will plan her birth. So first you will stabilize and then expedite birth. Either you could offer her induction of labor or you would do a CS depending on what is the gestation, the size of the cervix or the state of the fetus. Very important thing again, I would like to stress that eclampsia doesn't happen only in the antenatal period. 44% happens in the postpartum period. So any woman with severe preeclampsia, be on your guard, keep monitoring her even in the postpartum period. And eclampsia, very important thing to remember, eclampsia is a clinical diagnosis. Do not delay your management. Do not delay giving magnesium sulfate, saying that I am waiting for the blood results and then I will give her magnesium sulfate. Please don't do that. Any woman, hypertension, pregnant, already a known case of severe preeclampsia, if she throws a fit, by default, it is eclampsia. So start treatment and then afterwards look for any confirmatory tests. Now, next coming to HELLP syndrome. So this is a variant of severe preeclampsia. So hemolysis means, how do you know that there is hemolysis? So LDH is raised. You will see it on the peripheral films, and haptoglobin is also raised. So the threshold for LDH, if it is more than or equal to 600. And what happens in the peripheral picture in the blood film, you could see schistocytes, haptoglobin decreases, and bilirubin increases because the RBCs get disrupted. Now, liver enzymes, AST or ALT, they are raised. If whenever AST is more than 70, you could label the woman as having HELLP syndrome. And thrombocytopenia, that is low platelets. So whenever it is less than 100, and at the maximum severe end, you could have platelets as low as 50. Now, how do women with HELLP present? What is the clinical presentation? So because the liver capsule is stretched, they present with right upper quadrant pain or epigastric pain. They could also present with nausea, vomiting, or malaise. Blood pressure might be mildly raised. Proteinuria may be absent. It's not necessary that proteinuria has to be present. And 15 to 20% of them have minimal hypertension or no hypertension. Many of these women, they present in the postpartum period, or they could worsen in the postpartum period. and it is a variant of severe PET. So it has to be treated as severe PET. What are the complications that you will get with HELLP? So disseminated intravascular coagulopathy is very common, around 20%, placental abruption, acute renal injury. It is more with HELLP than with preeclampsia alone. Because of the hematoma that is there in the liver capsule, you could get a rupture of the liver capsule, pulmonary edema, and respiratory distress. All these are complications with HELLP. Now coming to fluid management. Okay, remember to keep these women dry. That means keep the pulmonary bed dry because pulmonary edema is something that can kill the woman. So for these women, restrict fluids to 80 ml per hour. If there is no active bleeding or there is no loss anywhere else, fluid is restricted to 80 ml per hour or 1 ml per kg per hour. That is maximum. And what is the fluid that you would want to give? Hartmann's or normal saline, 0.9% normal saline is the preferred one. Now, remember something as peripartum oliguria. Okay, it is very common. So, if you have a urine output of more than 40 ml in 4 hours in the immediate postpartum period, do not say that she is oliguric and do not pump in more fluids for her. Just wait and observe because it's common to have oliguria immediately in the postpartum period. And remember that in the postpartum period, there is diuresis. So there is physiologically all the blood, all the fluid that is there in the extravascular space, it comes into the intravascular space, and there is diuresis occurring 36 to 48 hours postpartum. So do not get panicked if the woman starts having a larger amount of urine output. Please avoid giving large boluses, especially of crystalloids, because you will push this woman into pulmonary edema. Any woman who has persistent oliguria and acute renal injury or AKI, remember she needs input from the critical care unit. You might consider invasive monitoring for her. And furosemide or the role of diuretics, you will give only if pulmonary edema is present. Do not give furosemide if there is oliguria. Remember, there is something called as peripartum oliguria. So do not panic if there is peripartum oliguria and do not give her furosemide immediately. Okay. So pulmonary edema, when will you have it? Any woman with preeclampsia, if iatrogenic, if you are giving a fluid overload, if you are pushing in too much amount of fluids, because of the endothelial leak that is already there with preeclampsia, she will develop pulmonary edema. Listen for crackles. You can do a bedside echo also, but just put your stethoscope and auscultate the base of the lungs. If that is there, immediately you can give her furosemide. Sorry. All right. Now coming to timing of birth, because we just saw that the definitive management of preeclampsia is removal of the placenta. So when do you deliver these women? Those who have hypertensive disorders. Now, women, those who have chronic hypertension and that hypertension is well controlled. So for these women, there is no need to offer an early birth, no need to offer birth below 37 weeks of pregnancy, unless some other complication is there. Okay. The mode of birth will be as per the obstetric indication. It is not necessary that they will deliver by a CS or whatever whatever is the clinical features at that time that will decide the mode of birth. For women with gestational hypertension, you will offer birth from 37 weeks of pregnancy. The mode again, as per the obstetric indication. Women with mild or moderate preeclampsia, especially those who are controlled, well controlled, for them offer birth from 37 weeks. With women with severe preeclampsia or uncontrolled hypertension, okay, individualize these women. For them, if they are not being controlled with antihypertensives, you can offer them birth between 34 to 36 weeks of pregnancy. If they have been stabilized, they can also be offered birth after 37 weeks of pregnancy. They can deliver vaginally if the clinical picture is stable, if there is some compromise in the maternal or the fetal status, you could offer her a cesarean section. Any woman with eclampsia, stabilize her immediately first and then expedite birth. Eclampsia, remember, is not a contraindication for a vaginal birth, but if she is remote, like she is very early, then instead of inducing, you could just offer her a CS. For HELLP also, first stabilize the woman, then expedite birth. Most of them do deliver by a cesarean section. Remember to offer antenatal steroids between 24 to 34 plus 6 weeks of pregnancy, especially if you are anticipating birth within 7 days. Now, some of the trials that were there, that is the Phoenix trial, it says that planned early term delivery between 37 to 37 plus 6 weeks in late preterm preeclampsia, that reduces the maternal morbidity versus giving her an expectant management. And remember that the fetus, if less than 30 weeks, offer magnesium for neuroprotection of the fetus. So please do not forget the role of steroids and magnesium sulfate for the fetus also. Now coming to postpartum hypertension, because women those who have preeclampsia, we know they could be having postpartum hypertension, and some of them are at a risk of developing cardiovascular disease in the long term. So it's important to control their blood pressure in the postnatal period, and you have to counsel them about the long-term risks. So the postpartum blood pressure target is less than 140/90. Remember to stop methyl dopa within 48 hours after birth because it gives rise to depression or suicidal tendencies. The drugs that are preferred in women, those who are breastfeeding, enalapril is first line. Then you have labetalol, nifedipine, atenolol, or metoprolol. How often should you be monitoring the blood pressure? So day 3 to 5, at least once. Then once between day 7 to 10. Then after 2 weeks. And at 6 to 8 weeks again, if she is still on antihypertensives. One important thing that you have to remember is that blood pressure often peaks at day 5 in the postpartum period. And any woman who comes back again with signs and symptoms, they do come back at this point of time. Women, those who have gestational hypertension, the recurrence is about 16%. And women, those who have preeclampsia, the recurrence rate is 13% in the next pregnancy. And this recurrence rate with preeclampsia, it is higher if preeclampsia developed early. At any woman developing preeclampsia at 28 weeks or 32 weeks, for them, the recurrence rate is higher in the next pregnancy. Any woman with preeclampsia, remember it is a high risk factor, so offer her aspirin from 12 weeks in the next pregnancy. Women, those who have preeclampsia, they are at a increased risk of hypertension, IHD, stroke, type 2 diabetes. So for these women, you will offer them annual blood pressure checkup, advise them to lose weight, keep a check on the glucose levels and the lipid levels. So you have to offer them lifestyle modification in addition to doing a blood pressure check at every year. Now coming to PRESS. So what is PRESS? PRESS is basically posterior reversible encephalopathy syndrome. How do you, just 1 minute. All right. So any woman who has some atypical features, okay? Normally women with preeclampsia, they would not be having, like they would be having some amount of headache, but if that headache or the visual changes, they are not responding to your normal line of management. Think of PRESS. And what you would do is order an MRI immediately because that is the confirmatory test that is there for PRESS. The treatment is basically supportive, treat her blood pressure, and most of these women with press, they do revert back to normal. Cortical blindness. It is a part of press, but remember here also you will have to rule out a stroke. Do not say that any woman with preeclampsia who is having blindness, it could just be cortical blindness. Remember, preeclampsia is also another high risk factor for developing stroke. Sorry. So again, you will do an MRI for her to make it to come to a diagnosis. Any woman with hyperreflexia and clonus, remember any woman who has hypertension, you know she is preeclampsia. If she has hyperreflexia and clonus, it is a sign of imminent eclampsia. So immediately start for her magnesium sulfate infusion. Whenever there is epigastric pain or right upper quadrant pain, it is because of the liver capsule stretch that is there. So think immediately of HELLP. Do the liver function tests urgently. Any woman who has a collapse in the postpartum period and she has new onset hypertension in the postpartum period, consider eclampsia, or it could be intracranial hemorrhage, it could be AFE, it could be pulmonary embolism, or it could be HELLP. So these are all the various diagnoses that you have to think of for any woman who has a postpartum collapse and she has new onset hypertension in the postpartum period. Now, there is something called as an atypical preeclampsia, where the woman has hypertension, but there is no proteinuria. If you have read the NICE guideline very properly, you will know that preeclampsia is not only hypertension plus proteinuria. Preeclampsia could also mean hypertension plus any organ dysfunction. So, please, if any woman is hypertensive, no proteinuria, look for organ dysfunction. So you will do a creatinine, platelet, AST or ALT, and especially women, those who are presenting with atypical headache. Think of press. Now, atypical or early onset PET, less than 34 weeks of pregnancy. Remember that these women, they have severe placental disease and they have a very higher rate of recurrence. We saw normally it is around 16%, 13 to 16%. But for women, those who have early onset preeclampsia, for them, the recurrence rate is up to 25% in the next pregnancy. Now, most of the postpartum eclamptic seizures that occur, they occur within 48 hours after birth. That is the commonest time. But some of them can present even up to 4 weeks. So don't shake your hands off and say someone coming up to 4 weeks after she has delivered that no, this is not eclampsia. It could still be postpartum eclampsia. Any woman who complains of headache, especially this headache, that is the worst ever headache. She describes as that this headache is the worst ever headache I had in my life, or this headache, it woke me up from my sleep, or this headache is there in the occipital part of the head. Don't take it lightly. Do an image first to come to a diagnosis, and the treatment part will be secondary. So imaging is very important for headache that wakes up the woman from her sleep, headache that is occipital, or headache that is worst ever. It is usually some kind of thrombosis that she could be having. It could be a cortical venous thrombosis or something happening in her head or even press. Now coming to the counseling, okay, and embrace and service issues. So previous PET, we already saw the recurrence risk is about 13 to 60% higher if preeclampsia occurred early. Remember to give aspirin from 12 weeks of pregnancy. Offer lifestyle changes. That means BMI has to be reduced pre-pregnancy. If she is on ACE inhibitors or ARBs, you have to change the drug. Smoking, alcohol, exercise, you have to offer them lifestyle counseling. Folic acid, not really important in preeclampsia. You will give it only if high dose folate, only if the BMI is more than 30, or any woman who is on anti-epileptics or she is diabetic. Always remember to do baseline bloods. That means FBC, Usenis, LFT, urate, and albumin creatinine ratio. And mild thrombocytopenia is not a contraindication for aspirin. Please remember this. What are messages from Embrace that you have to remember? Hypertensive disorders remain top 5 direct cause of death. Intracranial hemorrhage from uncontrolled severe hypertension is preventable, so please treat the hypertension very aggressively. Severe hypertension has to be treated within 15 to 30 minutes. There is no wait and watch policy for severe hypertension. Whenever there is headache and a blood pressure rise, it is a red flag sign. Please remember this: headache and a blood pressure rise. Please be on your high alert. Magnesium sulfate is sometimes underused in severe preeclampsia. Whenever you have any signs and symptoms that indicate this woman is likely to develop eclampsia, please use magnesium sulfate immediately. Use Muse or Mios as early warning scores. Okay? And always, communication failures is something which is very important. So please remember to have an open communication line with your patient and the relatives. Some never or always things that you have to remember for your exam point of view. Never, never, ever give ACE inhibitors, ARBs, diuretics, or direct oral anticoagulants in pregnancy. Never use methyl dopa beyond day 2 postpartum because it gives rise to depression and suicidal tendencies. Never give large bolus IV fluids. It can give rise to pulmonary edema in women with preeclampsia. Do not chase urine output target, especially remember that entity of postpartum oliguria. Do not diagnose preeclampsia on blood pressure alone. Okay, I look for proteinuria or look for organ dysfunction. And never, never discharge any woman with preeclampsia or severe preeclampsia without a 6-week BP plan. Okay, now what about the things that you will always do for women with preeclampsia? Always treat severe blood pressure, severe hypertension, more than 160 by 110. You will treat it as an emergency. It has to be treated within 15 to 20 minutes. Always give magnesium sulfate in women with eclampsia and severe preeclampsia. Always restrict fluids to 80 ml per hour in the peripartum period. This is always, of course, if there is no active bleeding or no active loss going on. If creatinine is more than 90, remember, you will halve the dose of magnesium sulfate. Maintenance dose, you will give only 0.5 milligrams. When you are not certain or uncertainty is there that this woman is likely to develop preeclampsia or not, check the SFLT to placental-like growth factor ratio. Always counsel women about the long-term risk of cardiovascular disease and counsel them that in the future pregnancies, they would be needing aspirin. All right. So important things that are there or top SBA pearls for you. Remember, aspirin from 12 weeks, more than 1 high risk factor or more than 2 moderate risk factors. Magnesium sulfate loading dose is 4 gram over 5 to 10 minutes. Maintenance is 1 gram. You will continue it for 24 hours after birth or after the last seizure. For gestational hypertension, you will deliver from 37 weeks and even for mild to moderate preeclampsia of a birth from 37 weeks. If the SFLT to placental-like growth factor ratio is less than 38, preeclampsia is unlikely in the next 1 week. Remember, it is for prediction, not for diagnosis. Recurrence, gestational hypertension around 16%, preeclampsia around 13%. And remember to give aspirin in the next pregnancy, especially women, those who have previous preeclampsia. 44% of eclampsia occurs in the postpartum period. So you have to be vigilant for 6 weeks after birth in any woman who has preeclampsia. Phoenix trial, it supports planned early term delivery in late preterm to reduce maternal morbidity. So do not give too much of a conservative waiting time for women, those who are already term. Okay. Now some of the traps that are there. Okay. You have this woman who has a BMI of 35. She is multiparous. Her age is 32. No other risk factors. Will you give aspirin? Remember here, she has only moderate risk factors. So you will not give aspirin. Okay. BMI of 35, that is the only moderate risk factor, only one. So no role of aspirin. Another woman who is multiparous at the age of 41, her BMI is 35. You will give her aspirin because she has two moderate risk factors, BMI and age more than 40. Any woman with a single reading of blood pressure 162 by 110, is it an emergency? Yes, it is an emergency. You will repeat the blood pressure within 15 minutes. And if it is confirmed that the blood pressure is the same, it is an emergency and you will treat it within 15 to 30 minutes. Woman, day 5 postpartum with a blood pressure of 158 by 100 and she has headache. Will you give magnesium sulfate now? Remember, treat the blood pressure first. If she has signs and symptoms of preeclampsia, you can consider giving magnesium sulfate. But first here, treat her blood pressure. A woman with severe preeclampsia, 33 weeks, she is on labetalol. Will you deliver her now immediately? Before you start making a plan for delivery, you will stabilize her. You can try and increase her dose of labetalol, give her steroids because she's just 33 weeks, and you can plan her birth at around 34 weeks, unless at this point of time, at 33 weeks, you have the maternal labs are deteriorating or there is some deterioration in the fetus. Any woman with SFLT to placental growth factor ratio of 25 at 28 weeks, will you admit her? Remember, whenever the ratio is less than 38, it is unlikely that this woman is going to develop preeclampsia. So there is no role to admit her. You can give her outpatient management. A woman who has eclampsia and for her already magnesium sulfate is running and she has a recurrent seizure, what do? Remember, to give her another dose of magnesium sulfate in addition to the 1 gram that is already going on. Give her 2 grams of magnesium sulfate over 5 minutes. Okay, and if the fits are still persisting, then you can give her diazepam. All right. Let us see a few SBAs that have been seen in the previous exams. Always for SBAs, always put up the cover test, read the stem very carefully, think of what is the answer, then uncover all your options and then search the option that you were looking for. Okay? And always in your mind, think of why you thought of this option. So always justify your answer. So you have this 32-year-old Gravida 1, 32 weeks of pregnancy, attends with a blood pressure of 162 by 108. So I will put this in my mind. Okay, she has hypertension. And this is confirmed after 15 minutes. So this is now definitely severe hypertension. She has proteinuria 2 plus, but she's asymptomatic. CTG is reassuring. What will be the single next step, best step? She doesn't have any signs and symptoms, but only she has hypertension. So what do you want to do for her? Obviously, you want to give her some antihypertensive agent. They have not mentioned that she is asthmatic or anything. I would like to go ahead and give her labetalol. Let us see what is the options that we have given here. Okay. So oral labetalol 200 milligram and review in 1 hour. IV labetalol 20 milligram bonus. Do an immediate cesarean section. Give hydralazine or give methyl-dopa. Obviously not methyl-dopa, very slow. I would even not go ahead with the CAT1 section because CTG is normal. I would not like to review her after 1 hour. So what is the correct option over here? The correct option is to give intravenous labetalol, 20 milligram bonus, because it is an emergency. And you will again review her in 15 to 30 minutes and titrate. If she's not responding, you could titrate the dose of labetalol. Hydralazine is a good option, but first line, remember, is labetalol. If labetalol is not working, then only you will go ahead and give hydralazine. Now you have a 30-year-old. She is gravida 2, para 1. She has had severe PT at 30 weeks of pregnancy in her first pregnancy requiring delivery. That means she has early onset preeclampsia. Now she is planning her second pregnancy. So what is the most appropriate aspirin advice? Remember, for aspirin to act, it has to be started at 12 weeks. Before 16 weeks, you will start it at 12 weeks of pregnancy. No aspirin needed. This is wrong. Aspirin, yes, from 12 weeks, you will start, not from a positive pregnancy test, only if she develops hypertension. It's not an antihypertensive, remember. And aspirin, we don't give 300. So here, the option of from 12 weeks, that is the one that is correct. Okay. So these are a few things that you have. This is something that you have to remember in your exam. Remember the classification. Then preeclampsia is anyone who has hypertension after 20 weeks of pregnancy plus proteinuria or organ dysfunction. You will give aspirin from 12 weeks of pregnancy if there is more than or equal to one high risk factor or more than or equal to two moderate risk factors. If the SFLT to prostaglandin to placental-like growth factor ratio is less than 38, it is unlikely that this woman will develop preeclampsia. And for diagnosis of preeclampsia, protein creatinine ratio should be more than 30 milligram per millimole. Coming to acute management. So a blood pressure of more than 160 by 110, remember it's an emergency. The first drug that is advised by NICE is IV labetalol. Target of 150 or less in 1 hour. For treatment or prophylaxis of eclampsia, you will give magnesium sulfate 4 grams of a loading dose and then maintenance of 1 gram for 24 hours or after birth or after the last seizure, whichever is later. Now, eclampsia, first stabilize the woman. Don't forget your ABCDE approach. And remember, magnesium is the drug of choice. And for HELLP, remember the Mississippi class 1 to 3. All right. Now coming to the time of birth and management after birth. So in women, those who have preeclampsia or women, those who have gestational hypertension, offer them birth from 37 weeks. The fluids you would like to give is give around 80 ml per hour and make sure that the urine output is more than 40 ml in 4 hours. Stop methyl dopa within 48 hours after birth or within 2 days after birth. Blood pressure will peak at day 5. So always offer a review on day 5 postpartum period. The risk of recurrence of preeclampsia is 13%. For gestational hypertension, it is 16%. And any woman with hypertensive disorders in pregnancy, they have a long-term risk of developing cardiovascular disease. So offer them annual screening of blood pressure and also lifestyle changes. Okay, so that comes with that, we finish off with hypertensive disorders. Let us start with, let us start with thrombosis and antiphospholipid syndrome. Now remember, pregnancy is a hypercoagulable state. Why is it a hypercoagulable state? It is because your body, the body, it anticipates that after birth, there is going to be a lot of blood loss. And in order to prevent that blood loss during the pregnant period, the body starts synthesizing more factors that are prothrombotic. Okay, so factors like 7, 8, 10, von Willebrand's factor, and fibrinogen. All of these factors which help the blood to clot the levels of these factors, they rise in pregnancy, or what we call as a procoagulant tilt. This is one of the survival mechanisms of the body to prevent postpartum hemorrhage. Now, protein S, which is a naturally occurring anticoagulant, we don't want the body to have a lot of anticoagulants in pregnancy or in the postpartum period. So the levels of protein S, they fall in pregnancy. So the anticoagulant effect also decreases. Women, those who have acquired activated protein C resistance, the levels increase. Again, the anticoagulant level falls. Plasminogen activator inhibitor, type 1 and type 2, both of them increase in pregnancy. So fibrinolysis decreases. And the clot that is formed becomes stable. Okay. Now the gravid uterus, it causes venous stasis. Again, this goes in a procoagulant tilt, or there is a predilection for left iliac vein thrombosis. Whenever there is endothelial injury, either due to delivery, due to a cesarean section, or due to sepsis, because of this, these women, they have a predilection or the procoagulant effect. It increases in the postpartum period or in the peripartum period. So that is why we say that in the postpartum period, these women are always, the risk of venous thromboembolism always increases in the postpartum period. It is very high for women, those who have undergone a cesarean section, or any woman who has any type of sepsis in the postpartum period. They are at a very high risk of developing venous thromboembolism. In pregnancy, whenever you have a deep vein thrombosis, 70% of these are on the left side. That is, if you remember your anatomy of part 1, it is because the right iliac artery, it compresses the left iliac vein. So DVT in the left leg is always more common than in the right side. And the highest risk of VTE in the postpartum period is day 0 to 6, particularly after a cesarean section. It is because of all these physiological factors, and also because these women can be immobile, they would not be well hydrated, all the other factors that contribute to increased rate of venous thromboembolism. Now, the charts that are there in the guideline, they are very important, and you have to know them by heart. Okay. Because to do the risk scoring, you have to do the risk scoring very accurately, not only in your clinics, but even in your exam, because even if the score is missed by 1, your option goes wrong and you lose that question. So those charts, you have to be prepared, and you have to know which risk factor, what is the point for that risk factor. Okay. So this risk scoring, you have to do it at booking. Any woman who is admitted in the antepartum or in the postpartum period, again, the risk scoring has to be done, and risk scoring has to be done immediately postpartum. So once the woman has delivered. Remember, previous venous thromboembolism due to any cause, it has a score of 4, except the one that is there due to a previous surgery. A woman has had a previous surgery, and after the surgery, she developed a venous thromboembolism. So that has a score of 3. But unprovoked ones have a score of 4. These women are at a very high risk. They have a score of 4. And for these women, you will start low molecular weight heparin from first trimester, and you will continue it for 6 weeks in the postpartum period. This has to be firmly imbibed in your head. Please remember this. Anyone with a known high-risk thrombophilia, it is a score of 3. Any medical comorbidities, again, it is a score of 3. Family history of unprovoked or estrogen-provoked DVT or VTE, it is a score of 1. Low-risk thrombophilias are score of 1. Age, more than, remember, age, it is more than 35. Okay. BMI, More than 30 is a score of 1. BMI of more than 40, remember it is 2. Please remember this. BMI more than 40 is a score of 2. Parity more than or equal to 3. So anyone with parity 3, her score, remember, is 1. Anyone with a parity 4, again, her score is 1. So parity, it is more than or equal to 3. Anyone smoker, active smoker, not a passive smoker. If the husband is a smoker, the woman doesn't get a score of 1. Gross varicose veins. It has to be really gross varicose veins, not superficial thrombophlebitis. Multiple pregnancy, and if it is a pregnancy due to ART or IVF, again, that is a score of 1. So all this has to be done in the antenatal period. Okay, and remember this BMI, it is BMI or weight at booking, not the BMI that you are seeing later on in pregnancy. Okay. Okay. Now, how do you decide in the antenatal and the postnatal period when you are going to start low molecular weight heparin for this woman? So you see her risk, the score that she has at the booking visit. Okay. See her antenatal score, whether it is equal to 3 or it is more than 3, less than 3, more than 3. Now, if her score is more than or equal to 4, you will start for her low molecular weight heparin from the first trimester and you will continue it for 6 weeks in the postpartum period. If the score is equal to 3 in the antenatal period, you will start for her low molecular weight heparin from 28 weeks and you will continue it for 6 weeks in the postnatal period. If the score is less than 3, she doesn't qualify for low molecular weight heparin in the antenatal period. But supposing this woman who has a score of 2 and she is admitted for a period of more than or equal to 3 days, it becomes a transient risk factor and she needs low molecular weight heparin only for the period that she is indoor. Once her discharge has been planned, you will stop the low molecular weight heparin for her. Okay. Now, once this woman who is on low molecular weight heparin, she has delivered. Or woman, she is not on low molecular weight heparin, but any woman, she has delivered. In the postnatal or the postpartum period also, you will do a scoring for her again and see the score. Any woman who has a score of more than or equal to 2, you will give her low molecular weight heparin for a period of 2 days. If she is at a very, so women, those who have had like say, she has had a previous VTE prior to her pregnancy, she is someone who is at a very high risk. So for her, you will continue her for low molecular weight heparin for 6 weeks. Or the general rule is that any woman who is on low molecular weight heparin from 28 weeks or anyone who is on low molecular weight heparin in the antenatal period, you will continue it for 6 weeks postpartum. Or anyone with a score of 3 or 4 in the postpartum period, you can continue low molecular weight heparin for 6 weeks. Now, what about the dose? Okay, so this is given in the guideline. I'm not going to read the dose because it doesn't make sense. You have to know this by heart. The only thing that you have to remember is that when you are calculating the dose of low molecular weight heparin, please remember to calculate the dose by her booking weight, not the current weight. In the exam, the common pitfall, the trap that is there, they will give you her weight at booking. They will give her, now you will say that she is around 28 or 29 weeks of pregnancy. She had a long distance travel and she developed a deep vein thrombosis. And her booking weight was say what 50, 55, and now her weight is 90. So calculate the dose of low molecular weight heparin that you want to give her. Please remember the dose that you are going to calculate, it should be based on her booking weight, not her weight at 28 or 29 weeks of pregnancy. That is a common pitfall, that the trap that is there, and all of you fall into that trap into the exam. So please remember, the dose has to be calculated by the booking weight. Okay. Now coming to some practical points about low molecular weight. Okay, the drugs that we use are enoxaparin, dalteparin, and tinzaparin. Okay, and the weight, depending on her weight, the dose is already decided. Now coming to postnatal, if the score is more than or equal to 2, you can give her for 10 days, but anyone with the previous venous thromboembolism, give for 6 weeks. If the weight of the woman is more than 170 kg, the dose you will split it and give it 2 times in a day. Those women who are on prophylactic doses, remember to stop the prophylactic dose of low molecular weight heparin 12 hours prior to giving regional anesthesia, either spinal or a epidural block. And those who are on the therapeutic doses or treatment doses, for them, the dose of low molecular weight heparin, it has to be stopped 24 hours prior to giving the neuraxial block or prior to giving spinal or regional anesthesia. When do you restart? Okay, once the woman has delivered. So if she has delivered by a cesarean section under spinal anesthesia, if there is no bleeding in the postpartum period, you can resume the low molecular weight heparin 4 hours after giving spinal anesthesia. Or if she was on an epidural catheter, you can resume it 12 hours after removing the epidural catheter. Now, low molecular weight heparin is a drug which is considered to be very safe, and you really do not have to monitor the woman very frequently. But there are some indications when you need to monitor the levels of anti-10A. So in extreme weight, when weight is less than 50 or more than 90 kgs, whenever there is renal impairment or there is recurrent venous thromboembolism, in spite of the woman being on low molecular weight heparin, you will monitor the 10A levels, anti-10A levels, and the target or peak level is 0.5 to 1.2 international units per ml. Okay. Okay. Now coming to acute venous thromboembolism, what is the diagnostic algorithm? Whenever you have any woman, remember an acute venous thromboembolism or a pulmonary embolism, it is a life-threatening condition. Clinical suspicion is there, treat it first, then treatment like low molecular weight heparin, then go and do the investigations. Do not wait for the investigations before you initiate or start giving low molecular weight heparin, because low molecular weight heparin in pulmonary embolism is a life-saving drug for that woman. Okay. So whenever you have clinical suspicion of venous thromboembolism, start the dose, low molecular weight heparin, the treatment dose you will start. Then you will look out whether it is deep DVT or it is pulmonary embolism. If you are suspecting a deep vein thrombosis, you will do a compression duplex ultrasound of the leg. If it is negative, but your clinical suspicion is high, you can repeat the ultrasound on day 3 and 7 again. If there is pulmonary embolism, okay, you will do an X-ray chest and you will look out for signs and symptoms of DVT. If there are signs and symptoms of DVT, you will do a compression duplex ultrasound of the lower limb wherever you are suspecting a DVT. If ultrasound is negative, okay, if DVT is confirmed, there is no need to do any further investigations. But if there is no DVT, have a look back again at her X-ray chest. And then if the X-ray chest is normal, do a VQ scan. If X-ray chest is abnormal, you can go ahead and do a CTPA. Okay. Now, what about the treatment of venous thromboembolism? So the drug of choice is low molecular weight heparin. It is given in a dose of 1 milligram per kg 2 times in a day. And remember, it is always the booking weight. If you want to give it once a day, the dose is 1.5 milligram per kg. Now, if it is in the antenatal period, this therapeutic dose is continued throughout pregnancy. If the venous thromboembolism occurs in the postnatal period, you will give it at least 6 weeks postpartum. The minimum total duration should be at least 3 months. Please remember this. The therapeutic dose of low molecular weight heparin you will give at least for 3 months. In the postpartum period, you can either continue with low molecular weight heparin, or if the woman is not comfortable taking injections every day, you can switch over to warfarin or rivaroxaban. But rivaroxaban you cannot give in breastfeeding mothers. Warfarin is safe in breastfeeding. Please remember this. And you will keep the INR between 2 to 3. Now, the oral anticoagulants you will not give in pregnancy and lactation. Okay, so please avoid them because we have limited data available for them. Any woman who has massive pulmonary embolism, unfractionated heparin intravenously, that is the drug of choice for her. But if the woman is unstable, a thrombolysis is indicated. IVC filters we usually do not offer in pregnancy, but if there is recurrent venous thromboembolism in pregnancy, in spite of giving anticoagulants, or there is any contraindication to anticoagulants, then you would be offering her an IVC filter. One thing you have to remember, D-dimer is never done in pregnancy because physiologically there is an increase in the level of D-dimer in pregnancy. So D-dimer for diagnosis of venous thromboembolism has no role in pregnancy, as also the Wells score. For pregnant women, we do not use the Wells score at all. Another important thing to remember is that whenever you are suspecting pulmonary embolism in any woman, and if you find that there are signs and symptoms of DVT, you will do a compression duplex ultrasound. If that ultrasound confirms that there is DVT, there is no need for further imaging because we already know that there is a DVT and that the thrombus, it has broken off, it has gone and lodged in the lungs and given rise to a pulmonary embolism. So if your compression duplex ultrasound is showing DVT, do not do any further imaging for the woman. Now, next coming to antiphospholipid syndrome. So how do you diagnose? What are the criteria? You need at least one clinical or one laboratory criteria to come to a diagnosis of antiphospholipid syndrome. So what are the clinical criteria? If there is vascular thrombosis anywhere, it could be arterial, it could be venous, or even it could be a small vessel thrombosis. Or if the woman has had more than one unexplained fetal death after 10 weeks of pregnancy, at or after 10 weeks of pregnancy. Or she has had more than or equal to one preterm birth less than 34 weeks of pregnancy. That means she has severe preeclampsia or placental insufficiency, giving rise to birth less than 34 weeks of pregnancy. Or she has more than or equal to 3 consecutive unexplained miscarriages before 10 weeks. So any one of this clinical criteria plus one laboratory criteria. Now remember, for this laboratory criteria, they have to be done 2 times on 2 occasions more than or equal to 12 weeks apart. If you are doing it only once and you find an abnormal level, please do not label the woman as having antiphospholipid syndrome. The laboratory criteria, they have to be repeated after 12 weeks. And after 12 weeks, if the criteria come out to be positive, only then you will label her as having antiphospholipid syndrome. So what are these laboratory criteria? If lupus anticoagulant is positive, or anticardiolipin antibody, IgM or IgG, in the medium or high titer, or anti-beta-2 glycoprotein, 1, IgM or IgG, if it is positive at more than the 99th centile. Any one of this, if it is positive 2 times, okay, more than 12 weeks apart, then you will label her as having antiphospholipid syndrome. Okay. Now, what about this antiphospholipid syndrome? Triple positivity, lab triple positivity. So, if any woman has all these 3 lab criteria as positive, they have the highest thrombotic risk. They are at a very high risk of developing thrombosis. And for them, you will consider, remember, therapeutic dose of low molecular weight heparin in the antenatal period, even though they have not had a previous venous thromboembolism. Okay, we give therapeutic doses of low molecular weight heparin to women, those who have an acute thromboembolism right now. But women, those who are lab triple positive APS, for them, you will give therapeutic dose of low molecular weight heparin in the antenatal period, even though they have not had any prior event. Okay? Because these women are at a very high risk, remember, they will be followed up in the high risk multidisciplinary team clinic. And who all will be there in the multidisciplinary team? You will have a rheumatology and a hematology specialist. Okay, so lab triple positive, these women are very high risk for having a thromboembolism. Now, how do you manage these women, those who have antiphospholipid syndrome? Okay, so any woman who is only antiphospholipid positive, but no APS criteria, that means lab criteria are not positive. If she is pregnant, then you will only give her low dose aspirin from a positive pregnancy test. No need to give low molecular weight heparin. But women, those who have antiphospholipid syndrome and they have recurrent miscarriages at less than 10 weeks of pregnancy, for them, you will start aspirin and prophylactic, remember prophylactic, not therapeutic, prophylactic low molecular weight heparin right from a positive pregnancy test. For preeclampsia, we give aspirin from 12 weeks of pregnancy. For women with APS, it has to be started once the pregnancy test is positive. And in addition, you will also give low molecular weight heparin. Now, anyone with antiphospholipid syndrome plus late pregnancy loss, severe preeclampsia, fetal growth restriction, again from there for them, aspirin and prophylactic low molecular weight heparin from positive pregnancy test. APS, previous thrombosis, again for them, you will give aspirin, low molecular weight heparin antenatally, and plus in the postpartum period, 6 weeks, because there is previous history of thrombosis. Anyone who is on long-term warfarin, of course, she has APS and long-term warfarin, you can switch to low molecular weight heparin in the pre-pregnancy period or by 6 weeks. Because remember, warfarin is a drug which is teratogenic. And the teratogenic effect of warfarin is seen between 6 to 12 weeks. So if she wants, she can continue warfarin. But once the pregnancy test is positive, you will immediately switch from warfarin to low molecular weight heparin. Women, those who are triple positive APS, we saw they are at a very high risk. So they will be under the care of the multidisciplinary team. Again, for them, aspirin and therapeutic low molecular weight heparin. Remember, it will be therapeutic here. And those who have catastrophic APS or what we call as CAPS. Okay. So for them, you will give them anticoagulants, you will give them steroids, immunoglobulins, or plus and minus plasma exchange. And remember, they will be admitted to intensive care and they would be under the care of the rheumatology team. So what is the meaning of CAPS? Whenever you have more than multi-organ thrombosis in a period of less than 1 week, okay, multiple thrombolic events in a period of less than 1 week, it is something that you call as CAPS. And why is it important? Because the mortality rate is very high. It has a 50% mortality rate. And what would be the triggers for this CAPS? So any woman who has infection, anyone who is undergoing surgery or AC withdrawal, that means anticoagulant withdrawal. She has stopped the anticoagulation by herself without asking her doctor. So this woman is at a risk of developing CAPS. Now, women, those who have mechanical heart valves, these are someone who are at a very high risk of developing thromboembolism in pregnancy. And the anticoagulant that you have to give them, it's always a dilemma because they are already on warfarin. We know warfarin is one of the best anticoagulant agents, always better than low molecular weight heparin. But warfarin, as we saw, it is not very safe in pregnancy. So always there will be a multidisciplinary team to take care of the woman. Now, what are the options that these women have? So you can give them low molecular weight heparin throughout pregnancy without monitoring anti-10A levels. But we saw that low molecular weight heparin is not a very good anticoagulant agent as compared to warfarin. So for the mother, there is a higher risk of valve thrombosis, especially those women who have been having the valves for a prolonged period of time. For the fetus, it is good, low molecular weight heparin, because they are not exposed to warfarin, so no warfarin embryopathy. Or they could be on warfarin throughout pregnancy, the other option. So for the mother, it is very good because there is no risk of valve thrombosis, but it is not good for the fetus because they can have warfarin embryopathy from 6 to 9 weeks of pregnancy. Also, there could be CNS malformations and there could be bleeding into the fetus. So it is warfarin throughout pregnancy is not a safe option for the fetus. The other thing that you could do, the other option for these women is you could give them low molecular weight heparin in the first trimester. In the second trimester, switch over to warfarin. Early third trimester also, she could be on warfarin. At term, say around 36 weeks of pregnancy, switch over from warfarin to low molecular weight heparin. So with this plan, the risk for the mother is intermediate. For the fetus also, the risk of embryopathy is reduced because you're not giving warfarin in the first trimester. So the fetal risk is also intermediate with this plan. Now, for women, those who are on low molecular weight heparin, what are the targets that you would want for anti-10A levels? So the peak should be 1 to 1.2. That means 4 hours after the dose of low molecular weight heparin. The trough should be 0.6 to 0.7. And for these women, you have to give them low molecular weight heparin 2 times in a day. OD dose is not usually sufficient. And when you are shifting them from warfarin to low molecular weight heparin, you will monitor the levels of anti-10A at least weekly initially. Now, what are the red flag signs with warfarin in pregnancy? The risk is high whenever the woman is on a higher dose. So if the dose is more than 5 milligrams per day, the risk of embryopathy is about 4 to 10%. If the dose is lower than 5 milligrams, the risk of embryopathy is lower. Remember to avoid warfarin between 6 to 9 weeks of pregnancy. That means the first trimester. And any woman who is on warfarin, switch to low molecular weight heparin or unfractionated heparin around term. That means after 36 weeks, do not give warfarin. And even warfarin in the immediate postpartum period, you will not give. You will start her on warfarin again, maybe after 5 to 7 days after birth. All right. So we have been talking about anticoagulants. The commonest one that we use is low molecular weight heparin. But you could also be using warfarin. You could be using unfractionated heparin. These are the other choices. Then you have the direct oral anticoagulants or you have fondaparinux. So low molecular weight heparin is safe in pregnancy, breastfeeding, and we know it does not cross the placenta. And we have good antidotes for them. So protamine sulfate is a partial antagonist. Now, unfractionated heparin is safe in pregnancy. It is also very good for acute venous thromboembolism, for massive pulmonary embolism. It is good for women, those who have mechanical valves. It is safe in breastfeeding. And you have a very good antidote by protamine sulfate. Only thing with unfractionated heparin is the risk of heparin-induced thrombocytopenia. You have to be very careful with that. Warfarin, we already saw it is teratogenic from 6 to 9 weeks of pregnancy, but it is safe in the postpartum or in women those who are breastfeeding because it is not excreted in milk. INR, you have to maintain between 2 to 3 for women, those who are on valves, preferably 3. The antidote that you have for warfarin, vitamin K, because we know warfarin, it stops production of vitamin K dependent factors. And so vitamin K is a good antidote for warfarin toxicity, and you have prothrombin complex concentrate or PCC. Now DOACs, you will avoid in pregnancy because limited data is available on their safety. You will not be giving DOAC to anyone who is breastfeeding. If any woman is on DOAC, you will stop it in the preconception period. Please remember, unlike warfarin, which you can continue up to 6 weeks, DOACs you will not give. She has to stop it in the preconception period, and you will switch her over to low molecular weight heparin. Now, fondaparinux, again, we have limited data, but if a woman has heparin-induced thrombocytopenia, fondaparinux is a good alternative for her. The data is limited for breastfeeding, and if you want to use fondaparinux, it is always under the guidance of a specialist. Okay. A few one-liners. Sorry. Okay. So heparin-induced thrombocytopenia or HIT, it is very rare with low molecular weight heparin, about less than 1%, but it is higher with unfractionated heparin. So any woman who is on unfractionated heparin, you will always be checking her levels of platelets. Then about reversal. So protamine for low molecular weight heparin, the reversal is partial. For unfractionated heparin, the reversal is full. For warfarin, the antidote, like we just saw, it is vitamin K and PCC. And for DOAC, you have either andexanet or idarucizumab. These are the antidotes for the oral anticoagulants. Okay, I think we have already seen this. We will go through it quickly. About anticoagulation and regional anesthesia. What is the timing matrix for spinal or epidural? So whenever the woman is on prophylactic dose, you will stop it at around 12 hours before the block, and you will restart it 4 hours after the block or 12 hours after removal of the epidural catheter. Anyone on treatment or therapeutic dose, it has to be stopped more than or equal to 24 hours before the block. You can restart it 4 hours after spinal or 24 hours after removal of the catheter. It depends on what your anesthetically has to say. Now, unfractionated heparin. We know the half-life of unfractionated heparin is very short. So if you are giving it subcutaneously in a prophylactic dose, you can stop it about 4 hours before the block with a normal APTT level. Okay. And it can be restarted 1 hour after your spinal or epidural anesthesia. Unfractionated heparin intravenously, if you are giving the therapeutic dose, it has to be stopped more than 4 hours with a normal APTT before giving the block, and you can start it 1 hour after the neuraxial block. Women, those who are on warfarin, before you want to give spinal or regional anesthesia, you will stop it 5 days. These women have to be basically put on bridging thromboprophylaxis. And you will check her INR and make sure that it is less than 1.5, because if the INR is higher, there is a risk of bleeding. And warfarin can be started the same evening after giving spinal or epidural. So oral anticoagulants, we saw that you will avoid in pregnancy. In non-pregnant women, they have to be stopped 24 to 48 hours prior to spinal or epidural anesthesia, and restarting afterwards, it is different for each agent. So you need not go into details of that. Now, aspirin or NSAIDs. Low dose aspirin. I'm talking about low dose aspirin. There is no need to stop because some of the guidelines do say that you will continue aspirin whenever you are giving it for prevention of preeclampsia till birth. So there is no need to stop aspirin before giving spinal or epidural. And if you want to restart it again afterward for any other reason, it depends on what your anesthetic colleague has to say. One of the important points, this OAA or AAGBI, these are basically guidelines for anesthesia. Okay. So what is the safety rule? They say that document timing of the last low molecular weight heparin dose on every anesthetic chart. Sorry. On every anesthetic chart, because this is one of the most common cause of avoiding epidural hematomas in obstetrics. Okay. So if the woman is like she is taking the treatment dose of low molecular weight heparin and it is only 12 hours since the last dose she has taken, and you post her for a cesarean section, and she has been given either a spinal block or she has been given a epidural block, it can give rise to a epidural hematoma. So it is very important to document the timing of the last dose of low molecular weight heparin on every anesthetic chart. Now, coming to venous thromboembolism in special situations. So, which are these special situations? Ovarian hyperstimulation, hyperemesis, long travel, especially air travel more than 4 hours, then cesarean section, and sickle cell disease. So, ovarian hyperstimulation, remember, it is a very high risk factor for developing venous thromboembolism. And you do not have to give, like this woman who has ovarian hyperstimulation, you do not have to give her low molecular weight heparin throughout pregnancy. You will give her till the OHSS has resolved, so till end of first trimester, and anytime she is admitted in the first trimester, you will definitely give her low molecular weight heparin. Now with hyperemesis also, it is only for women those who have been admitted. Why? Because they are admitted, they are dehydrated due to the hyperemesis, and plus they are immobile in hospital because they are under IV fluids and all those things. So low molecular weight heparin only during admission, not when she is at home. Okay, once she goes home, once you decide to discharge her, you can stop the low molecular weight heparin from her. Any long haul travel, especially more than 4 hours. So it is a mild risk factor. For them, you can offer them TEDs and tell her to remain well hydrated. TEDs means these are the stockings that you get, anti-embolism stockings. And you can tell her that she has to be well hydrated during the flight and she can take walks inside the flight as well. But if she has other high risk factors for developing venous thromboembolism, then you will give her low molecular weight heparin only for the period of travel. Okay. So if she has a high BMI of more than 40, remember it is BMI of more than or equal to 40, as it is a score of 2. And plus now she is having a long travel for 6 hours. So now her VTE score becomes 3. But because her VTE score is 3, you will not give her for around 28 weeks until the pregnancy is over. Only for this point of travel, when she is traveling now, her score has become 3. So only for the day of travel, you can give her low molecular weight heparin. Now, a cesarean section is add 1 point for that. So you will rescore her in the postpartum period and you will give her low molecular weight heparin if the score is more than or equal to 2. A planned cesarean section has a score of 2, whereas a planned cesarean section has a score of 1. Emergency has a score of 2. Please remember that. Emergency cesarean section is 2 points, not 1. Now, sickle cell disease, 3, because it is a medical comorbidity. So for these women, you will give from 28 weeks and continue for 6 weeks postnatal, whatever she delivers vaginally or by a cesarean section. Acute COVID or sepsis, again, inflammatory states, you will give low molecular weight for the duration of admission in hospital. Once she is discharged, she can be off low molecular weight heparin. Okay. Important points to remember that postnatal low molecular weight heparin is the highest So, to reduce the maternal VTE death, you will always remember to score her in the postpartum period and start low molecular weight heparin if indicated. Venous thromboembolism scoring is done at every admission. Remember, booking 28 weeks and postpartum period. In addition to that, any pregnant lady at any time she is admitted, especially if the admission is more than or equal to 3 days, she needs low molecular weight heparin for the period of admission. Okay, these are the important things to remember about when you are going to do the VTE risk scoring. Now, never and always. So, never use Wells score or never do D-dimer in pregnancy. It is going to be, D-dimer is physiologically elevated in pregnancy, so of no use. Never give DOACs in pregnancy or breastfeeding. Never wait for imaging before we want to start low molecular weight heparin if VT is suspected. It is a life-saving drug. Give the drug first, then do your investigations. Never stop aspirin or low molecular weight heparin, especially in women with APS without a specialist input. Never use warfarin between 6 to 9 weeks of pregnancy, and never forget to document the last dose of low molecular weight heparin, especially the women who are going to deliver, like they are being planned for a neuraxial blockade. Some things that you will always do. You will always score the VTE risk at booking, admission, after birth, and even at 28 weeks. Don't forget that. You will start the treatment dose of low molecular weight heparin on clinical suspicion of DVT or preeclampsia or, pulmonary embolism. Do not wait for investigations or do not wait for imaging. That can be done later on. Any woman who has venous thromboembolism in the antenatal period, continue low molecular weight heparin for 6 weeks in the postpartum period. Always offer aspirin and low molecular weight heparin for women, those who have antiphospholipid syndrome and recurrent miscarriage. Always the dose of low molecular weight heparin, the dose you will calculate by the booking weight. It will never be the current weight. Okay, if the booking weight is not given, see her weight in early pregnancy, but do not use the weight at 28, 29, 30 weeks of pregnancy, whatever. Earliest weight that is available, that is the weight that is to be used for dosing of the low molecular weight heparin. And VTE risk score, you will recalculate after every admission. Okay. Now, what are the top SBA pearls that we have for venous thromboembolism and antiphospholipid? Remember to do booking, to do the risk scoring at booking, admission, and after birth. Rescoring is examined repeatedly. Please remember that. The treatment dose of enoxaparin is 1 milligram per kg if you want to give it 2 times in a day. If you want to give it 1 time in a day, it is 1.5 milligram. And always it is booking weight. Please fix this in your head. Now, you have any woman with pulmonary embolism, you will do an X-ray chest and bilateral leg ultrasound first, okay? If DVT is confirmed, there is no need for further investigations. No need to do a VQ scan or a CTPA. Remember, VQ scan is always preferred over CTPA in pregnancy because of the lower maternal breast radiation that is there. DOACs are always avoided in pregnancy and breastfeeding. Any woman with APS, recurrent miscarriage less than 10 weeks of pregnancy, you will give low dose aspirin and prophylactic low molecular weight heparin from a positive pregnancy test. Okay. And women, those who have mechanical valves, for them, you can give low molecular weight heparin with monitoring of anti-10A levels, or you can also give them warfarin, but it will be based on the decision of the multidisciplinary team. So these are some important things that you have to remember from exam point of view. Now let us see what are the traps that the college lays out for you in the exams. Let us see a scenario. You have someone who is heterozygous with FVL. FVL is factor 5 leading. Okay, she is heterozygous, not homozygous. BMI is 23, age is 29. Will you give her antenatal low molecular weight heparin? What is her score? BMI is low, age is also 29. She has only one factor, and that also has a score only of 1. So in the antenatal period, you will not give her low molecular weight heparin. Okay. You have another lady who is heterozygous for FVL and her BMI is 42. When will you start for her low molecular weight heparin? So for her now, her score becomes 3 because BMI of 42 means the score is 2 and FVL is a score of 1. So 1 plus 2 becomes 3. So you will give her from 28 weeks. And she will also, remember, she will need it 6 weeks postpartum. Okay? Any woman whose age is exactly 35, what is her score from the age point of view? So age exactly 35, remember, score is 0. The threshold is more than 35. Please remember this. Okay. Now, you have a woman, she has a previous venous thromboembolism, which was provoked by a road traffic accident and because of her immobilization. So, for her, when will you give her low molecular weight heparin? Remember, this is provoked by RTA, but there is a difference between this scenario and this one. So previous DVT after major surgery, that has a score of 3. So for her, you will start from 28 weeks. This woman, she has not had any surgery. The DVT or the VTE that she has had, it is provoked because of immobilization. So this woman is definitely at a very high risk of developing venous thromboembolism in pregnancy. So for her, you will start for her, it is basically a score of 4. So for her, you will start from booking and you will continue it for 6 weeks in the postpartum period. Okay. Now, you have another lady. She has a family history of a DVT, which was provoked because of a long haul flight. Someone in her family has undergone on a long haul flight, say 6 hours of 7 hours of a flight, and that person had developed a DVT during the flight. It is not this lady who developed a DVT due to the flight. So again, here the score is 0. Okay. So she does not need low molecular weight heparin. Now this woman, another woman, in the previous pregnancy, in the postpartum period, she had a DVT and she has completed her full dose of anticoagulation at this time. This is, we are talking about the previous pregnancy. This is the previous pregnancy. And now she has come to you for booking. Remember, this woman is at a very, 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 very high risk. So for her, you will start from her low molecular weight heparin from booking itself and continue it for 6 weeks in the postpartum period because she is very high risk for developing venous thromboembolism in pregnancy. All right. Let us come to a few SBAs that have been like what we saw them from the previous papers. Okay. Like I told you, please always use the cover test when doing SBAs. So you have this 28-year-old Gravida 2 para 1, 28 weeks of pregnancy. She presents with sudden pleuritic chest pain and shortness of breath. So you start your thinking process right now. Pregnancy and pleuritic chest pain, shortness of breath. Maybe she could have pulmonary embolism. We don't know as of now. She has tachycardia, heart rate is 120, SpO2 is 92. On the lower side, chest raise, respiratory rate 26, that means she's tachypneic. X-ray chest is normal. Bilateral leg ultrasound is normal. So what is the single next best step that you would be doing for her? Your thought process is she could be pulmonary embolism. You want to save her life. What will you do? You want to do some investigations because ultrasound is normal. You want to do a few other investigations. Will D-dimer help? No. D-dimer will not help in pregnancy. Maybe a VQ scan or a CTPA or ECG or an echocardiogram only. But remember, echocardiogram is not for diagnosis of pulmonary embolism. Okay. D-dimer also physiologically it is raised in pregnancy. So you cannot interpret it in pregnancy. Now here what they have given, X-ray chest is normal. So whenever X-ray chest is normal, the next step that you would be doing, if a DVT is not confirmed, you would be doing a VQ scan. So that is the correct option over here. Okay. CTPA also is an acceptable alternative, but CTPA is usually done when X-ray chest is abnormal. And also with CTPA, the radiation to the breast, maternal breast is higher. So you would not be doing a CTPA. And repeat ultrasound of the legs is not because sure ultrasound is normal. So there is no DVT as of now. So repeating it is not going to help you. Okay. All right. Now, you have this 32-year-old. She's a gravida 4, para 0, 3 first trimester miscarriages. So she has recurrent pregnancy loss. She is 6 weeks pregnant and APS is confirmed for her. Okay. She is lupus anticoagulant positive on 2 occasions, 14 weeks apart. That means she is confirmed APS APLA syndrome. She has no previous thrombosis. What is the most appropriate treatment management for her? She is only lupus anticoagulant positive. She is not lab triple positive. Please keep that in mind. And also there is no history of previous thrombosis for her. Will you give her only low dose aspirin or will you give aspirin, low prophylactic, low molecular weight heparin? Or will you give therapeutic low molecular weight heparin or will you give warfarin or steroids and IVIG? Steroids, IVIG definitely out of question. Warfarin also definitely out of question. See, she has 3 first trimester miscarriages and she also has APS. She is confirmed. So only aspirin is not going to help her. You have to decide between these two. If she is lab triple positive, you can give her therapeutic. But if she is not triple positive, for her prophylactic dose is enough. And also there is no previous thrombosis. So if she has previous thrombosis, then you can give her therapeutic low molecular weight heparin. Okay. Okay. Now you have again this 38-year-old gravida 3 para 2 with a BMI of 41. And she had an emergency CS for failed induction of labor at 39 weeks. That means it is a term pregnancy. She is not preterm. Labor was 22 hours. Vaginal delivery attempt failed. She is now postnatal day 1. What is the most appropriate VTE prophylaxis? So here you have to do her scoring. Age is 38, means it is a score of 1 because she is more than 35. Now she is para 3, right? She's already delivered. And emergency CS, again a score of 2. So her score becomes very high. She is almost at a score of 4 now. So for her, you will give her low molecular weight heparin for 6 weeks in the postnatal period. All this is her factors now. Okay. So she definitely needs low molecular weight heparin. If her score was more than or equal to 2, then low molecular weight heparin for 2 days would have been adequate, but her score is high. So she needs for a longer period of time. There is no point in giving aspirin because it is not an agent for prevention of VTE. And IVC filter is not indicated for her over here. Okay. Now, what are the basic, the things that you have to remember in the summary? So remember, scoring for VTE, you have to do at booking, at admission in the postpartum period. If the score is more than or equal to 4, you will start low molecular weight heparin. from first trimester. If it is 3, you will start from 28 weeks. Postnatal period, if the score is more than or equal to 2, you will give for 10 days. Anyone with previous VTE, you will give for 6 weeks. Always use booking weight to decide the dose of low molecular weight heparin. And any woman during pregnancy, postpartum period, if she needs readmission or admission, you will do a scoring again for her. Rescoring has to be done. Now, for acute venous thromboembolism, Wells and D-dimer is not used. For treatment, low molecular weight heparin, the dose is 1 milligram per kg. If you are giving 2 times a day, if you want to give 1 time, you will give 1.5 milligram per kg. For anyone with pulmonary embolism, you will do an X-ray chest and ultrasound, lower limb ultrasound first. If ultrasound confirms that there is DVT, no need to go ahead and do any other investigations. Always VQ scan is preferred over CTPA because there is less radiation to the maternal breast. Anyone with acute VTE in pregnancy, you will give low molecular weight for a period of 6 weeks in the postpartum period. And oral anticoagulants, you will always avoid in pregnancy and during breastfeeding. Now, what about APS and those women, those who have valves? So the Sapporo classification, it says that to diagnose APLA syndrome or antiphospholipid syndrome, you should have 1 clinical and 1 lab criteria. Sorry. But remember this lab criteria, remember it has to be done 2 times more than and 12 weeks apart. Doing it only once is not enough to diagnose the woman as having antiphospholipid syndrome. Now, any woman with antiphospholipid syndrome and recurrent pregnancy loss, you will give aspirin and prophylactic low molecular weight heparin. Anyone with antiphospholipid syndrome plus previous history of thrombosis, you will give therapeutic low molecular weight heparin. Understand the difference. With previous thrombosis, you will give therapeutic. If there is no previous thrombosis, it is only prophylactic. Anyone with triple positive, all the 3 lab parameters are positive, they are at a very high risk. And you will always put them under the care of a multidisciplinary team. Anyone who has mechanical valves, mechanical cardiac valves, you can give either low molecular weight heparin or warfarin. And those who have caps, you will, those who have caps, they need admission in the ICU, they need steroids, they need intravenous immunoglobulins, and they need anticoagulants. Okay. Okay. These are 21 liners. I will give you just 2 minutes for you to read them by yourself, and then we will continue with the session again. I'm just giving it to you for 2 minutes. Please go ahead and read it by yourself. Only 2 minutes. Hope everyone has finished. Hope you've done with the reading. Let us go ahead. Okay. Okay. Now, what about drug reversal and how do you monitor? So we saw that whenever the woman is on low molecular weight heparin, we do not need to monitor anti-10A levels routinely. They are done only if needed. And if you want to give a reversal for low molecular weight heparin, it is protamine. It is given in a dose of 1 milligram per 1 milligram of enoxaparin. For unfractionated heparin, the APTT you have to monitor. The target should be 1 to 2.5 times of the control. And the reversal for unfractionated heparin again is protamine, 1 milligram per 100 units of heparin. And the reversal with protamine for unfractionated heparin, it is full. It is not partial reversal. For warfarin, the target level of INR is 2 to 3 or 3 for mechanical valves. If you want to give a reversal, you will give vitamin K 5 milligrams intravenously, and you can give PCC, that is the prothrombin complex concentrate. For aspirin, routinely we are not monitoring any levels, but if you think that there is bleeding happening in a patient who is on aspirin, you can give her platelet transfusion, especially if the bleeding is life-threatening. For dabigatran, no anti-10A levels are monitored routinely. If you need to give a reversal, the reversal is idarucizumab. For the other oral anticoagulants, routinely also, we do not monitor any levels. If at all you want to give, if needed, you could be given andexanet alpha if it is available, or you could use PCC as an alternative. And for fondaparinux, routinely these patients are on anti-10A level monitoring. Okay. And if you want to give a reversal, if there is a bleeding, you could be giving recombinant factor 8A concentrates. If you want to reverse the bleeding that is happening. Now, any woman who is on anticoagulants and she has major hemorrhage, always activate the massive transfusion protocol. Very important to stop the anticoagulant. Doesn't make sense. The anticoagulant is going on and you are giving her blood transfusion. So activate the massive obstetric or massive transfusion protocol. Stop the anticoagulant, give reversal. We just saw what is the type of reversal that you could be given here. And in addition to that, you can give tranexamic acid 1 gram intravenously. And if this woman is about to undergo any kind of surgery or anything, if facilities are available, you could consider intraoperative cell salvage if facilities are available in the hospital. Okay. Now, women, those who are on, they have had an episode of venous thromboembolism, you want to discharge her from the hospital. Remember, these women are very high risk. So you have to give them specific instructions. Okay. So you have to tell them about the duration of low molecular weight heparin, for how long they have to continue. So you have to continue it at least for a period of 6 weeks in the postpartum period after acute venous thromboembolism. Whether you want to switch to oral anticoagulants. So you could, it is optional. If she wants to continue with low molecular weight heparin, she could be doing that. If she wants to switch over, you can switch over to warfarin, keeping an INR of 2 to 3, or rivaroxaban. But rivaroxaban you will not give for breastfeeding mothers. As regards to future contraception, at all cost, you will avoid estrogen-containing methods because they are UPMEC4. Then in future pregnancy, you will counsel her that it's a very high-risk pregnancy and she needs low molecular weight heparin right from booking and for 6 weeks in the postnatal period, especially if this is an estrogen-related VTA. If it is related to surgery, you will start for her low molecular weight heparin from 28 weeks, but you will again continue for 6 weeks in the postpartum period. What about thrombophilia screening? If at all you want to do, you will wait for 6 weeks after stopping the low molecular weight heparin and then do the thrombophilia screen. Or the thrombophilia screen has to be done 3 months after the acute event. You will not do it during the acute event. Then compression stockings you will give for 1 year postpartum, or what is the local protocol, to reduce the risk of venous thromboembolism in future. You will advise her to stop smoking, lose weight, and maintain good hydration, especially when she is traveling. What about MDT follow-up? So she will be followed up in the multidisciplinary team, not only in the obstetric team, but also the hematology team will be following her up at 6 weeks in the postpartum period. So all these things have to be told to her at discharge. Okay, so that ends the topic of venous thromboembolism, mechanical valves, and antiphospholipid syndrome. Going forward, we will go ahead with metabolic and endocrine disorders. So the hot topic is diabetes, either pre-existing diabetes or GDM. Now, first let us see pre-existing diabetes. What all will you do for her in the preconception period? So always remember that the sugar levels, they have to be optimized before conception. What is the target of HbA1c? It should be less than 48 millimoles per millimole or less than 6.5%. If HbA1c is more than 86 or it is more than 10%, advise the woman to avoid pregnancy. Folic acid, you have to give high dose folic acid, 5 milligrams per day starting from the preconception period, and you will give it up to end of first trimester or till 12 weeks. Just 1 minute. Now, which are the drugs that you can continue in pregnancy? So, okay. Metformin, you can continue in pregnancy in the second trimester, and insulin, you can give right from first trimester, second trimester, and even third trimester. Which are the drugs that you are going to stop? So, sulfonylureas, not to be given in pregnancy, semaglutides, not to be given in pregnancy, GLP-1 agonists, and gliptins. Do not give in pregnancy. All these drugs you have to stop in pregnancy. Statins, ACE inhibitors, angiotensin receptor blockers, you will stop in the preconception period, or once pregnancy test is positive, immediately within 48 hours, these drugs have to be stopped. Women, those who are diabetic, they will undergo a retinopathy screen in the preconception period, that means pre-pregnancy, first antenatal visit, and then again at 28 weeks. Similarly, nephropathy. So pre-pregnancy, you will do the albumin creatinine ratio. If creatinine is more than 120 or albumin creatinine ratio is more than 30, she needs referral to a nephrologist. And women, those who have diabetes, they have one high risk factor. So you will start for them aspirin from 12 weeks. They have one high risk factor for preeclampsia. So from 12 weeks of pregnancy, you will start for them low dose aspirin. Now coming to the antenatal management. So what is the target, the glucose target for these women, those who are diabetes, type 1 or type 2 diabetes, but pre-existing diabetes before pregnancy? So fasting should be 5.3 or less, 1 hour post meal 7.8 or less, and 2 hour post meal 6.4. These are the targets. Always remember that they should not be hypoglycemic. So the sugars should never be less than 4 millimoles per liter. Now, continuous glucose monitoring, as per the new guideline, NICE guideline, updated in 2020, you will offer continuous glucose monitoring to all type 1 diabetics in pregnancy. Insulin pumps, if they are taking in the pre-pregnancy period, they can continue during pregnancy and they will be followed up in the specialist clinic. All women, those who have diabetes, remember there is a high risk of having malformations in the baby. So a targeted anomaly scan is done at 20 weeks and also a fetal echo to rule out any cardiac anomalies. And then women with diabetes, they are at a high risk. There could either be macrosomia or there could be fetal growth restriction. So growth scans you will offer from 28 weeks every 4 weekly, 28 weeks, 32 weeks, and 36 weeks. What about steroids? Will you give steroids for women, those who have diabetes? So diabetes is not a contraindication to give steroids if the woman needs an early delivery, okay? And steroids are needed for maturation of the fetal lung. You can give them steroids. The only thing to remember that that the woman, she is going to need more insulin during that period. Okay, for a period of 24 to 48 hours, her insulin needs are going to be increased. Aspirin, we already saw, you will give her from 12 weeks. And venous thromboembolism, so pre-existing diabetes with microvascular complications. That is a risk factor. Or any woman with diabetes with retinopathy or nephropathy. The score is 1. Women with diabetes who do not have any microvascular complications, it is not a high risk factor for developing venous thromboembolism. Now coming to these women, what about their monitoring in intrapartum and postnatal period? So timing for birth. Women, those who are well controlled, that means the sugars are well controlled, you will offer them birth between 37 to 38 plus 6 weeks of pregnancy if there are no complications. If any complications develop, that means there is fetal growth restriction or there is macrosomia, there is polyhydramnios, or the sugars are not being controlled, you will offer her an early delivery. Now, the mode of birth. Remember, diabetes is not a contraindication for a vaginal delivery, nor is it a contraindication to offer her a VBAC. But if the expected fetal weight, if you are expecting macrosomia and the fetal weight is more than or equal to 4.5 kg, then NICE guidelines say you will offer her a CS. Otherwise, even a VBAC is not contraindicated in women, those who have diabetes. Now, in the intrapartum period, you will maintain glucose between 4 to 7 millimoles per liter. How will you do that? You can give her VRII, that is variable rate IV insulin infusion, or what we call as a sliding scale infusion. So the IV fluids that you are going to give her will be 5% dextrose, and in addition, you will give her sliding scale insulin to maintain her glucose between 4 to 7. What is this? What is the indication for this variable rate IV insulin infusion? Any type 1 diabetic in labor, any type 2 diabetics, if the glucose is more than 7, because we want to maintain it between 4 to 7. So glucose more than 7 is an indication to give sliding scale insulin. Or anyone who is GDM and she is on insulin, for her also you will give her sliding scale insulin in the intrapartum and postpartum period. Now, women, those who have pre-existing diabetes, type 1 or type 2, whatever, in the postnatal period, remember, there is a tendency for hypoglycemia, especially women, those who are breastfeeding, and also the stimulus that is there because of pregnancy, the human placental lactogen that is there, that will fall immediately once the placenta has delivered. Now, that human placental lactogen is the one that is responsible for all these increased needs of insulin during pregnancy. Once the woman delivers, there is a tendency for hypoglycemia. So, the dose of insulin that you are giving in the postpartum period, you will immediately reduce it to the pre-pregnancy dose. And this has to be immediate. Once placenta has been delivered, insulin dose has to go back to the pre-pregnancy level. For the newborn, because there is a risk of developing hypoglycemia, remember, you will monitor the glucose levels every 2 to 4 hourly. Breastfeeding or top feed, whatever, it has to be started within 30 minutes of birth. If the newborn shows signs and symptoms of hypoglycemia, shift the newborn to the NICU or SCBU. Breastfeeding is completely safe in women, those who are diabetic. So encourage the woman to breastfeed the baby, whether she is on metformin or insulin, both are completely safe during breastfeeding. And in fact, breastfeeding decreases the needs of insulin. So encourage breastfeeding for women, those who are diabetic. Future contraception, all types of contraception is indicated, or she can use any type of contraception that she wants. Ideally, offer her LARC because you want to give her some good contraceptive method. Now coming to GDM. What is the screening algorithm? So remember, in UK, screening for GDM is not universal. Only women, those who have risk factors for GDM, they are offered screening or they are offered an oral glucose tolerance test. In UK, screening for GDM is not universal. So please remember that. So on the booking visit, try to find out if the woman has any risk factor for GDM. If there is no risk factor, there is no routine oral glucose tolerance test offered to her. Now, if there is a risk factor, remember, the risk of developing GDM, it increases in the third trimester. So screening is done at 24 to 28 weeks. Only one scenario in which OGTT will be done at booking. Anyone who has previous history of GDM, these women are at a very high risk of having a recurrence of GDM. So GDM in a previous pregnancy, this woman is offered GTT at booking. Okay. Now, after you have done a GTT, remember your figures 5, 6, 7, 8. Even one is abnormal, you will label her as GDM. Okay. If GTT at booking, it is negative or it is normal. I'm not negative. If GTT at booking, it is normal, please do not leave the woman alone and tell her that, okay, fine, you don't have a risk of developing GDM in this pregnancy. Remember, risk of GDM increases as the pregnancy progresses. So if GTT is normal at booking, repeat GTT at 28 weeks. Okay. Now, what are the risk factors? Like we have risk factors for developing preeclampsia, there are risk factors for developing GDM. BMI more than or equal to 30 at booking. Please remember, at booking. For preeclampsia, it is more than 35. Previous baby weight more than or equal to 4.5 kgs. Previous GDM, first degree relative with diabetes, or some communities like South Asian, Middle Eastern, or Afro-Caribbean origin. Any one of these risk factors, and you will do screening for GDM. If no risk factor, screening is routinely not done in the UK. Please remember this. Okay. Now coming to diagnosis of GDM. We already saw, from MRCOG part 1, we know these figures of 5, 6, 7, 8. So you will do fasting glucose, make the woman drink 75 grams of glucose and repeat the blood glucose level at 2 hours. If fasting is more than or equal to 5.6, or after 2 hours it is more than or equal to 7.8, even one abnormal value, you will label her as GDM. HbA1c is not for diagnosis. Okay, for GDM. It is not as diagnosis for GDM. Any woman who has a random glucose of more than 11.1 and with symptoms, consider her as overt diabetes mellitus. She is not GDM. She is overt diabetes mellitus. No need to do a GTT for her again. Okay. Now, some important things to remember about how you are going to do a GTT for her. So, the glucose load that is given is 75 grams glucose in 250 ml of water. She has to be fasting from 10 o'clock the night before. And you will not do, like the fasting period is, say, from 10 o'clock. It has to be at minimum of 6 hours of fasting. Okay. Then plasma glucose is done at 0 and 2 hours. Please do not offer GTT to any woman who has undergone any bariatric surgery or anyone who is having an acute illness. And remember, one abnormal value is enough to diagnose GDM. Now, in post-bariatric surgery, why will you avoid GTT? Because it leads to dumping syndrome. So for these women, instead you can offer them to do an HbA1c, or you could do fortnightly capillary glucose levels after 16 weeks. And then plus, because they have undergone a bariatric surgery, you will refer them to the specialist bariatric clinics, and you have to explain to them about the risk of hypoglycemia and the reactive hyperinsulinemia that can be there in these women with bariatric surgery. Now, the management of GDM. Okay. So it is always a stepwise management. Remember, in UK, they will not directly go on to any invasive methods. First, they will try all conservative methods, and if those fail, then only drugs and other invasive methods are chosen. So, step one, you have diagnosed that the woman is GDM. You will not immediately start her on metformin or insulin. First, you will offer lifestyle modification in the form of diet and exercise. You will give this for a period of 2 weeks. Okay, so 30 minutes of exercise, a diet that is low in carbs, and food that has low GI index. That is the first thing that you will do for her. Now, if after 2 weeks your targets are not met, then you can add metformin for her. Okay. And metformin, you will start 500 milligrams, start once a day, twice a day, titrate, and then monitor her sugar levels and decide whether you want to increase or keep her on 500 milligrams once a day. Now, what about insulin? Will you directly add insulin? So, there are specific indicators when you will first start insulin for this woman. So, if the fasting glucose level is more than or equal to 7 at a diagnosis of GDM, fasting is more than or equal to 7, that is an indication to start insulin immediately. Okay. Or women who have fasting of between 6 to 6.9, but there are some complications like there is macrosomia or there is polyhydramnios. For these women, you will first directly add insulin. Or for women, those who have done a lifestyle modification and plus they have given a trial of metformin, but still the glucose levels are not being maintained, then for them also you can add insulin. Okay. So the type of insulin that you can give long acting ones, and you can give a mealtime bonus in addition. So that is about insulin. Now, what about glibenclamide? So it is not first line drug like metformin or insulin. It is second line. If metformin is not tolerated by the woman, only then you will give her glibenclamide. Okay. And or the woman, she doesn't want to take insulin, then glibenclamide can be given for her. What about self-monitoring of glucose levels? So all women, those who are on diet control or those who are plus or minus metformin and plus or minus insulin, they will be doing fasting glucose levels and they will be doing 1 hour post meal. So this is all women, those who are GDM, they will be doing fasting and 1 hour post meal. The target is fasting less than 5.3 and 1 hour post meal less than 7.8 or 2 hour post meal less than 6.4. This is something which you have to remember. Okay, this is for women, those who are GDM. Now, women, those who have GDM, again, for them, they are at, if especially uncontrolled, they are at a risk of developing macrosomia and polyhydramnios. So growth scans you will offer at 28, 32, and 36 weeks. Women with GDM, those who are well controlled, they do not need early delivery. For them, you can offer them delivery by 40 plus 6 weeks, vaginal birth or cesarean section, depending on what are the circumstances at that time. But if the GDM is not controlled or there are complications, you will offer her an earlier birth. Sorry. Now, what about GDM? The postnatal management and long term. Okay. So remember, women with GDM who are metformin and insulin, once they deliver, immediately stop metformin and insulin. You will screen them for type 2 diabetes and you will also offer them lifestyle measures, because remember, 50% of women, those who have GDM, in 5 years, they go on to develop type 2 diabetes. Okay. So immediately after birth, stop all hypoglycemic agents, insulin, metformin, stop immediately. For the newborn, you will measure glucose levels 2 hourly, start breastfeeding or top feeds, and if they still develop hypoglycemia, shift them to the NICU. From day 1 to 6 for the mother, check the glucose levels if she is symptomatic. Otherwise, you can, at discharge, you can do her sugar levels. Then fasting glucose, you will do between 6 to 13 weeks postpartum. Okay. Now, here, if the fasting glucose is more than or equal to 7, you will label her as type 2 diabetes immediately. If it is between 6 to 6.9, she is pre-DM, and you will refer her again for lifestyle modifications. If at 6 to 13 weeks fasting glucose is less than 6, that means it is normal. She doesn't have diabetes right now. Okay. Because we saw that these women can develop type 2 diabetes, you will offer them annual HbA1c, 50% risk of developing type 2 diabetes. Diabetes in one pregnancy, in the future pregnancy, do GTT at booking. And if GTT at booking is normal, repeat again at 28 weeks. There is no need for giving them low dose aspirin because it is not a high risk factor for developing preeclampsia. They have to be offered lifestyle changes. So they have to optimize the BMI with diet and with exercise. And it has been seen that lifestyle changes, they substantially decrease the risk of developing type 2 diabetes. Counsel these women that breastfeeding reduces long-term type 2 diabetes in the mother, and plus it also prevents obesity and the other metabolic problems for the baby. So you have to encourage these women to breastfeed the newborn. So that was all about diabetes. Let us next go and see hypothyroidism in pregnancy. Remember that once any woman pregnant, any woman with hypothyroidism, she is pregnant, she needs to increase her dose of levothyroxine, and the targets for TSH, they have to be very tightly controlled, especially in the first trimester. So the dose of altroxin or levothyroxine, it has to be increased by at least 25 to 50% once pregnancy is confirmed. Of course, you will not do it yourself. You will refer her to the endocrine clinic. Why it has to be increased? Because during the first trimester, there is increased production of thyroid binding globulin, and the thyroid hormones, they bind to this thyroid binding globulin, and less are available for circulation. Okay. Plus, there is placental transfer of the thyroid hormones. And also the demands of the thyroid gland itself, they increase in pregnancy. So the dose of levothyroxine, you will increase once the pregnancy is confirmed. Now, the target for TSH in the first trimester, please maintain it below 2.5. Target for TSH in the second and third trimester, usually it is less than 3. And any pregnant woman who has known hypothyroidism, her TSH levels will be monitored every 4 to 6 weeks. Now, what about women, those who are subclinical hypothyroidism? That means the TSH levels are raised, T4 levels are normal, and the woman doesn't have any signs and symptoms of thyroid disease. That is, she is having subclinical hypothyroidism. So for these women, they will be treated only if TSH is more than 4 or thyroid peroxidase antibodies are positive. Or thyroid peroxidase antibodies are positive, and this woman, she is planning a pregnancy. So in the pre-pregnancy period itself, you will start treatment for her. Okay. Any woman who has new onset hypothyroidism in pregnancy, you will start treatment for her immediately, because otherwise it affects the neurodevelopment of the fetus. The fetus is likely to become a cretin if the woman is also hypothyroid. So immediately you will start for her treatment. What is the need? I mean, how much is the need of iodine in pregnancy? Remember, the fetus, the mother is the source of iodine for the fetus. So there is more transplacental transfer of iodine. So in pregnancy, the need of iodine increases. It becomes around 150 to 250 micrograms per day, because the fetus starts its own thyroid production by 10 weeks of pregnancy. So it needs large doses of iodine, and the mother is primarily the source through the placenta. So the mother needs more amount of iodine in pregnancy. Now, once the woman has delivered, she will come back to her pre-pregnancy dose of LT4 or levothyroxine. Now, coming to hyperthyroidism and drug, we know two types of drugs are used, carbimazole or propylthiouracil. Both of these drugs, they cross the placenta, and both of these drugs have some side effects. So we have to see which is safer in pregnancy. So propylthiouracil is the drug that is preferred in the first trimester. Okay. Why is it preferred? Because with carbimazole, there is an increased risk of having aplasia cutis, that means the scalp development is affected in the fetus, and also there could be choanal atresia in the fetus. So first trimester, always give propylthiouracil, that is PTU, and carbimazole you will give in the second and third trimester. Why? Because with PTU, the risk of hepatotoxicity for the mother is high. Hepatotoxicity risk with longer use. So to prevent that, give PTU in the first trimester, carbimazole in second and third trimester. As with all drugs, remember to give the lowest effective dose, okay, so that you will minimize the transplacental transfer and you will prevent fetal hypothyroidism. Now, what about thyroid antibodies? So, any woman with Graves' disease, you will check these thyroid antibodies in the second and third trimester, especially because we know that they could be crossing over into the placenta and they could also be affecting the fetus. Now, women, those who have hyperthyroidism, they are at a risk of developing a thyroid storm. So, how do you treat this thyroid storm? You will give PTU, you will give propranolol because with a thyroid storm, there is tachycardia. So, propranolol, which is a beta blocker, it will help to control the heart rate. Plus, you will give iodine and hydrocortisone and treat whatever is the precipitant cause of the thyroid storm. Okay. You have to know a little bit about postpartum thyroiditis. Remember, women with postpartum thyroiditis, first 1 to 6 months, they have hyperthyroidism. Then 4 to 8 months, it is hypo, and then they go on to recovery. The pathophysiology, we will be talking a little bit later of this postpartum thyroiditis. Okay. So this is how you are going to do. Switch first trimester PTU, second trimester carbimazole, and in the postpartum period also, you will continue with carbimazole. What is the treatment of thyroid storm? So PTU, 600 to 1000 milligrams loading dose, and then you will give 200 milligram oral every 4 hours. Sorry. Beta blockers. So propranolol, 60 to 80 milligram orally, 4 hourly, or you can give esmolol intravenously. Iodine, when you want to give, you will not give it with PTU, you will give it 1 hour after PTU. So Lugol's iodine is the iodine that is given. It is given 5 to 10 drops, 6 hourly, or if you don't have Lugol's iodine, you can give potassium iodide because that stops the production of thyroid hormones in the thyroid gland. Glucocorticoids, hydrocortisone, you will give because that blocks conversion from T4 to T3. We know T3 is the active thyroid hormone. So if the production of T3 is decreased, then you will help to tide over the thyroid crisis. And also supportive treatment. So cooling, IV fluids, and whatever is the precipitant cause for this thyroid storm. Where will you treat this patient? You will not treat her as an outpatient setting or in the wards. She has to be shifted either to the intensive care unit or to the unit, and a multidisciplinary team consisting of the endocrinologist, consultant obstetrician, anesthetic, and even the neonatal team. All of these are going to be involved in her care. This score, the Birch-Watowski score of more than 45, it is highly suggestive of a thyroid storm. Now, what about the fetus? So there could be fetal heart rate changes occurring. So you have to monitor the fetus very carefully, offer continuous electronic fetal monitoring. Remember, there is always a risk of fetal tachycardia. So monitor the maternal heart also. If the maternal heart rate is, there is tachycardia in the mother, it will reflect in the fetus also. Okay, so don't start panicking if there is fetal tachycardia. And sometimes because of this thyroid storm, it could later on lead to fetal growth restriction because of placental infarcts or something happening in the placenta. Now we saw that thyroid storm, there could be a lot of precipitating factors. So infection, someone who is hyperthyroid and not well controlled, she goes into labor with uncontrolled hyperthyroidism. Anyone who is having a cesarean section, someone with hyperthyroidism and preeclampsia, hyperemesis gravidarum with poor compliance. We already know that when anyone who has hyperemesis gravidarum, there is biochemical hyperthyroidism. So if this hyperemesis gravidarum is not well controlled, that could sometimes lead to a thyroid storm. Women, those who have diabetic ketoacidosis, or sometimes women, those who have hypothyroidism and they have trauma due to any cause, that could also precipitate a thyroid storm. Now coming to postpartum thyroiditis. So I will just explain to you a little bit about the pathophysiology. So any woman, those who have thyroid antibodies, okay, what happens in the first trimester in pregnancy? Because we know pregnancy is an immunosuppressive state. So these thyroid antibodies, they usually do not manifest. So they will not show signs and symptoms of hyperthyroidism. But in the postpartum period, what happens is once the woman delivers in the postpartum period, the immunosuppressive phase of pregnancy that is removed and the woman gets back her own immunity. So these thyroid antibodies that are there, now they attack the thyroid gland and they cause destruction of the thyroid cells. Once the thyroid cells are destructed, they release all the thyroid gland or the thyroid hormone that is present in the thyroid gland that is suddenly pushed into the circulation. So this happens first 1 to 6 months in the postpartum period. There is destruction of the thyroid gland. More thyroid hormones are being pushed into the circulation. So first 6 months, you will get hyperthyroidism. Okay. So this happens usually in women, those who have thyroid antibodies. Now, once the thyroid gland is destroyed, all the thyroid hormone is released into the circulation. Later on in the recovery period, what happens? 6 to 8 or 12 months, the thyroid gland is totally destructed now. And there is no thyroid hormones that are being formed in the thyroid gland. So later on, these women, they develop hypothyroidism. Okay. After about 1 year or so, they do regain back the normal thyroid function, but 30% of them do develop permanent hypothyroidism. Okay, so this is in short about the pathophysiology of postpartum thyroiditis. So if there is hyperthyroidism, you can get anxiety, palpitations, and tremors. You can give a beta blocker if the woman is symptomatic. If she doesn't have any symptoms, no need, but definitely there is no role of giving any antithyroid drugs for these women. Once they become hypothyroid, you need to give thyroid replacement. So levothyroxine is given and you can consider stopping it at about 12 months. We saw that from 12 to 18 months in the postpartum period, once they are in the recovery phase, they regain the thyroid function, but 30% of them develop permanent hypothyroidism and then they need thyroid replacement therapy. Okay. So a few important points that you have to remember that there is an increased risk. So anyone who has thyroid antibodies and pregnancy, those who are type 1 diabetics or those who have previous postpartum thyroiditis, all of them, they are at a high risk of developing postpartum thyroiditis. Then you will do TFTs at 6 to 8 weeks in the postpartum period, especially if the woman is symptomatic, and you have to distinguish it from Graves. So what is the distinguishing point? In Graves, thyroid antibodies will be positive, whereas they will be negative in postpartum thyroiditis. And any woman who develops postpartum thyroiditis, annually you will be doing TSH for them, like once in a year, because we saw 30% of them become permanently hypothyroid. And this symptoms, sometimes anxiety, palpitations, you could think that it is because of postnatal depression or some peripartum psychiatric disorders. They can exist, they can coexist, but always keep in mind that it could also be a feature of postpartum thyroiditis. So any woman who is having any symptoms like this, you have to screen for postpartum depression as also screen for postpartum thyroiditis. Next, coming to obesity in pregnancy. Okay. So we know whenever the BMI is more than or equal to 30, you will call it as obese. So there are two types, more than 30 or more than 40, which is considered to be morbidly obese. Care of these women for in pregnancy. So they need high dose of folic acid, that means 5 milligrams of folic acid from the preconception period, and you will continue it at least up to 12 weeks of pregnancy. Aspirin, because it is a high risk factor, you will consider from 12 weeks of pregnancy. Then thromboembolism, VTE prophylaxis, you will rescore them in the postpartum period. So if the score is 2, you will give it for 10 days. Whereas when the BMI is more than 40, remember, BMI of more than 40, the score is already 2. You will start scoring her from antenatal period. If there are more factors, she will need in the antenatal period also, and in the postpartum period, at least for a period of 10 days. If no other risk factors apart from a high BMI. Definitely, they will need screening for GDM. So at 24 to 38 weeks, you will do screening. And also for women, those whose BMI is more than 40, you will do early HbA1c because they could be overt diabetics as well. You don't know. The anomaly scan is offered to both of them. They might need a repeat anomaly scan because technically the scan is difficult to do. So it has to be done again with an expert. Women who have a BMI of more than 40 in the third trimester, you will refer them to the anesthesia team. Equipment that is needed when the BMI is more than 30 but less than 40, it is standard equipment. But for women, those whose BMI is more than 40, they need a bariatric bed. They can need a hoist to shift them, okay, because they have problems with mobility. And even the operating table that is needed, you need special tables, wider operating tables are needed. In the postpartum period, the management of women with the BMI of more than 30 is pretty standard for all the other women. But those who have a BMI of more than 40, they have definitely higher risk of venous thromboembolism. And if they have undergone a cesarean section, wound infection rate again is very high for them. Now, women, those who are planning pregnancy and they have undergone a bariatric surgery, they need specialist care in the form of the bariatric team has to be there with them. They need help from a nutritionist, and also there could be hidden emergencies in women, those who have undergone bariatric surgery. Okay. So women undergoing bariatric surgery, what is the ideal time for them to get pregnant? They have to avoid pregnancy for 12 to 18 weeks in the postoperative period, because that is the time by 18 weeks the weight stabilizes. 12 to 18 weeks is the time when they are losing weight rapidly after a bariatric surgery, and that is why it is not advisable for them to get pregnant during that period. After 18 weeks, the weight stabilizes and then they can embark on the pregnancy. They need supplementation, high dose folic acid, they need iron, they need B12, they need calcium, and also vitamin D supplementation. GDM screening, remember, you will not do for women, those who have undergone a bariatric surgery. They can get the dumping syndrome. Instead, for them, you will do HbA1c and you will do capillary levels from 16 weeks. Women, those who have undergone different type of procedures, like bariatric surgeries, also you have the Roux-en-Y, you have sleeve, you have band. All of them will have different types of deficiencies. So they could have iron deficiency, they have B12 deficiency, they have vitamin D deficiency. So for these women, it is very important to screen them for the nutritional deficiencies. So at booking, in each trimester and in the postpartum period, you will do their iron levels, you will do B12 levels, you will do folate levels, you will do vitamin D levels, calcium, vitamin A, vitamin K, and zinc levels. All these are very important for women, especially those who have undergone bariatric surgery. One thing you have to keep in mind for them that drug absorption is reduced for these women. If you give them large tablets, these tablets may not dissolve. So it is advisable to give them liquids or you can give them dispersible tablets. Risk of VTE is higher for them. So they need rescoring every time, booking 28 weeks, postpartum period. And in the postpartum period, at least for 10 days, they need low molecular weight heparin. Bariatric surgery by itself is not a contraindication to a vaginal birth. The mode of delivery, it depends upon the obstetric indication. You will always encourage these women to to go ahead and breastfeed the baby. And in the postpartum period, also continue for them supplementation with vitamin D and B12. Coming to other endocrine disorders, which are relatively uncommon, but you could be getting questions in the exam. So, prolactinomas. The thing that you have to remember is that bromocriptine or cabergoline, which is the medical management of prolactinoma, these drugs are contraindicated in pregnancy, so they are stopped. So, once these drugs are stopped, the pituitary may enlarge and you can get compromise in the visual field. So, you have to be on the lookout for compromise in the visual field for these women who have had a prolactinoma and they are now pregnant and the drugs have been stopped. For women, those who have acromegaly, you have to continue with whatever treatment they are on, but they will definitely need specialist care. And these women are particularly at high risk of developing GDM, more of growth hormone. Okay. Diabetes insipidus, desmopressin, safe in pregnancy, but cautious with women, those who develop preeclampsia. Okay. And the dose of desmopressin you may have to increase, especially in the third trimester. Cushing syndrome is something which is rare, but if it is there in a pregnant woman, the maternal fetal mortality is very high. She needs specialist input from the multidisciplinary team. Addisons, that means adrenal insufficiency. So they will be on replacement with hydrocortisone. The need increases in the third trimester. And whenever she is in labor or she undergoes any type of surgery or there is sepsis, you need to give intravenous hydrocortisone, usually 100 milligrams every 6 hours. That is the standard dose. Women with pheochromocytoma, very rare. So the first drug that you would give is you would give alpha blockade. Remember here also maternal mortality, fetal mortality is very high. And pheochromocytoma, because the basic pathophysiology is there is hypertension. So it could be mistaken for preeclampsia. But whenever you have labile hypertension, not responding to any of your hypertensives, you could suspect a pheochromocytoma. Then women, those who have hyperparathyroidism. So the miscarriage rate is very high. The rate of intrauterine fetal death is very high. So for these women, if she is symptomatic, you could offer her surgery in the second trimester. Whenever, like second trimester, we usually say the pregnancy is stable. So she could undergo a surgery to cure the hyperparathyroidism at that time. And maybe the fetal outcome would be better for her then. Women, those who have hypoparathyroidism, the levels of calcium are low. So you will give them calcium supplements, you will give them vitamin D supplements, and you will monitor the calcium and the vitamin D levels very closely. So this is something which could be managed with calcium and vitamin D supplementation. Now coming to never and always. Remember, in pregnancy, Never give semaglutides, never give GLP-1 agonists or sulfonylureas. Never, never, never in pregnancy. Never give carbimazole in the first trimester. You could have aplasia cutis in the baby. Women with post-bariatric, never offer them OGTT because they will develop dumping syndrome. Any woman post-bariatric surgery complaining of severe abdominal pain, you will never always think of this internal hernia. Never use HbA1c alone for diagnosis of GDM. Always do a GTT. And women, those who have type 1 diabetes, you will never forget to tell them to do continuous glucose monitoring. Now, what will you always do? Any woman with diabetes, high dose folic acid, any woman with obesity, more than a BMI of more than 30, anyone who has undergone bariatric surgery, they need high dose folic acid. Women with hypothyroidism, positive pregnancy test, increase the dose of levothyroxine by 25 to 50%. Pregnant women with past history of Graves or having Graves disease in this pregnancy, always check thyroid antibodies, second trimester and third trimester. Women, those who are GDM and they have delivered, stop hypoglycemics on the day of birth. Immediately, once the placenta has delivered, stop the oral hypoglycemics. Any woman with GDM, offer fasting glucose between 6 to 13 weeks in the postpartum period. Okay. And any woman who is diabetic, type 1 or type 2, offer her aspirin, low dose aspirin from 12 weeks of pregnancy because it is a high risk factor for preeclampsia. Okay, so these are the top pearls, the same thing that we just spoke now. We will go ahead and see a few traps that are there in the exam. Okay. So the scenario was that you have this type 2 diabetic and she is on the semaglutide and she is planning a pregnancy. What will you do for her? Remember, the semaglutides, they are contraindicated in pregnancy. You will stop the drug for her in the preconceptional period and you will switch either to metformin plus or minus insulin. Now, a woman who is type 1 diabetic, HbA1c of 95, she wants to conceive. Very high risk, advise her against pregnancy until the HbA1c becomes less than 86. So optimize the HbA1c first. Woman hypothyroid on carbimazole, 6 weeks pregnant, she's taking 20 milligrams. You will switch immediately to PTU in the first trimester because carbimazole can give rise to aplasia cutis in the baby. Now, a woman at 18 weeks of pregnancy, she is on PTU, 20 milligrams per day. Will you switch her drug or no? So the answer is yes. You will switch to carbimazole because giving PTU for a longer time, it can cause hepatotoxicity in the mother. Now, someone undergoing screening. So her fasting is 5.6 and 2 hours sugar is 7.5. What is your diagnosis? Now remember, fasting more than or equal to 5.6. And even if one value is abnormal, she is still GDM. So this woman, even though her 2 hours is normal, fasting is abnormal. So she is GDM. You have this woman with a BMI of 42. She is GDM and she is on metformin and insulin. What about the timing of birth? So GDM, she can go on to term. You will offer her, sorry, this is not at 30, she can go up to 40 plus 6, okay? Earlier, if she has any complications, okay? Especially GDM, those who do not have any complications, they can go up to 40 plus 6. If complications are there, or if the sugars are whatever, she develops polyhydramnios or macrosomia, or in spite of metformin and insulin, her sugar levels are not being maintained or not being controlled, then early delivery. Otherwise, she can go up to 40 plus 6. Woman with a bariatric surgery asks for a routine OGTT. Will you do for her? Definitely no. because she has the risk of dumping syndrome. Instead, for her, do HbA1c and capillary blood glucose levels. Okay. Now you have this woman with in the first trimester, she has severe vomiting, she has tachycardia, she has tremors. HCG, or maybe they mean to say that she is hyperthyroid. What will you do for her? You will just, so because of her hyperemesis gravidarum, she is showing signs and symptoms of hyperthyroidism. She doesn't need antithyroid drugs right now. Okay, you will only give her supportive treatment because this hyperthyroidism that is there in the first trimester because of hyperemesis, it is only transient. It doesn't need antithyroid drugs. Please remember that. Okay. Let us see a few SBAs on the endocrine disorders. You have this 28-year-old Gravida 1 with Graves' disease. She's taking carbimazole, 20 milligrams daily. She is 6 weeks pregnant now. Positive urine pregnancy test done at home is positive. What will you do for her? We just saw carbimazole. You will not give in the first trimester. So without looking at the options, you will say you will change from carbimazole. You will change to PTU. Okay. So all the options that are given here, continue carbimazole is wrong. Switch to PTU is the correct option. Stop antithyroid drugs. Definitely no. She needs antithyroid drugs in pregnancy. Otherwise, she will go into thyrotoxicosis. Only propranolol, no, because propranolol is given only to control the tachycardia or the tremors. It is not antithyroid. And radioactive iodine ablation, definitely not in pregnancy. Now you have this 34-year-old G2P1. Her previous baby weight is 4.6. She has OGTT at 26 weeks. Fasting is 7.2 and 2 hours is 8.5. What is the most appropriate immediate management for her? Remember, previous baby weight is 4.6. Now she is just diagnosed as GDM and fasting is 7.2. So when we saw that whenever fasting is more than 7, it is an indication to give insulin directly. Okay. But whenever you are giving insulin also, don't forget lifestyle changes. Diet and exercise, that has to be given. You will not give only insulin and tell her eat whatever you want and don't do any exercise. That doesn't work. Even if you are giving insulin, you will also advise her on diet and exercise. So that is why insulin therapy, diet and exercise, that is the correct option and all the other options are not correct. And glibenclamide, it will be second line. It will not, remember, please remember, whenever fasting is 7 or more than 7, it is an indication to start insulin immediately. Plus or minus metformin and also advise diet and exercise. Okay. And there is no role of conservative management, like wait for 2 weeks, offer diet, exercise, and then repeat. No, once fasting is 7 or more than 7, start insulin immediately. Okay. 31-year-old, undergone bariatric surgery 2 years ago. Now 24 weeks pregnant, sudden severe epigastric pain, vomiting, tachycardia, blood pressure 110/70, heart rate 115, WBC is 14. What is the most likely diagnosis? Remember, anyone who has undergone any bariatric surgery coming to you with severe abdominal pain, please don't forget internal hernias. That is one of the first diagnosis that should come to your mind. Okay, and it is a surgery. It's a surgical emergency. So that is the first thing that will come to your mind. Okay, hyperemesis gravidarum. It will not cause sudden abdominal or severe pain. Preeclampsia, it is not because her blood pressure is normal. Appendicitis, she will not have epigastric pain. Pain will be lower down. And pancreatitis, it is possible, but you want to have a look at her lipase levels. But pancreatitis is something which is rare as compared to internal hernia, especially women, those who have undergone bariatric surgery. So always choose the option that is more common rather than choosing the uncommon options. Now coming to the safety of drugs that we have we could be using in any women, those who have endocrine disorders. Metformin, completely safe in pregnancy and in breastfeeding. Insulin, any type of insulin, safe in pregnancy, breastfeeding. Sulfonylureas, glibenclamide is like for women, those who have GDM. It is not first line or second line drug. Only if she refuses insulin, she doesn't want metformin, only then glibenclamide can be given. SGLT2 inhibitors, you will not give in pregnancy and not even in breastfeeding. GLP-1 agonists also stop in the preconceptional period, do not give in breastfeeding. Levothyroxine, you will give, it is safe in pregnancy and in the postpartum or breastfeeding period also. Remember to increase the dose by 25 to 50% in the first trimester. Carbimazole, avoid in the first trimester. You can give in second and third trimester. In breastfeeding also, it is safe, but give it at a lower dose. PTU, only in the first trimester. Don't give for a longer period of time. It can be given in breastfeeding period also. Radioactive iodine, absolutely contraindicated in pregnancy. You will not even give in breastfeeding. Bromocriptine and cabergoline, they are usually stopped in pregnancy. In breastfeeding, you can give, but they are anyway going to suppress lactation. So you have to counsel the lady about what is the effect of these drugs in the breastfeeding period. So this is a summary of what we just discussed. Remember, for diabetes, HbA1c has to be less than 48 in the preconceptional period. Avoid pregnancy if HbA1c is more than 86. High dose folate has to be given to these women. For diagnosis of GDM, remember the numbers 5, 6, 7, 8. If the fasting for women with GDM, if fasting sugar is 7, start insulin. Continuous glucose monitoring offered to all women with type 1 diabetes. And for women, those who have GDM, if the blood glucose comes to normal in the postpartum period, you will do fasting glucose levels again at 6 to 13 weeks. Then about the thyroid gland. So you need to increase the dose of levothyroxine by 25 to 50% once the pregnancy test is positive. In the first trimester, the target for TSH is less than 2.5. PTU, you will give in the first trimester, carbimazole in second and third trimester. If any woman has Graves' disease, check thyroid antibodies level in second and third trimester. The treatment for a thyroid storm is PTU, beta blocker, iodine, and steroid. So iodine is Lugol's iodine. Okay. And for postpartum thyroiditis, remember 5% of these women, those who have thyroid antibodies, they can develop postpartum thyroiditis. It is biphasic. So initially hyperthyroidism, then hypothyroidism, and then you have the recovery phase. Now, women with obesity and post-bariatric surgery. So whenever BMI is more than 40, they do require high dose folic acid 5 milligrams. Those with a BMI of more than 35, it is a moderate risk factor. So aspirin, low dose aspirin, you have to consider. BMI of more than 40, refer them to the anesthetist. Women, those who have undergone bariatric surgery, avoid OGTT because of dumping syndrome. Instead, do HbA1c. If they present with severe abdominal pain, always think of internal hernias. And always remember, women, those who have undergone bariatric surgery, you have to keep a watch on them for deficiencies, all vitamins and micronutrients. All those deficiencies have to be screened for. Okay, now all the drugs that we spoke of today, okay? So aspirin, low dose, you will give from 12 weeks of pregnancy. Obviously safe in pregnancy, it is safe in breastfeeding also. Remember in the exam that you have to start minimal by 16 weeks. If you start later, the benefit of starting low dose aspirin is lost. After 16 weeks, it has no effect. For low molecular weight heparin, to calculate the dose, always calculate the dose based on the booking weight of the woman. LMWH, safe in pregnancy. If you want to give a treatment dose, you will give it 2 times, okay? And if you are giving it prophylactically, you will give it only once in a day. Labetalol, first line antihypertensive for treatment of hypertension in pregnancy. It is safe in breastfeeding. Please avoid in women those who have asthma. Methaldopa, antihypertensive, safe only in antepartum period. In breastfeeding, only up to 48 hours postpartum. After that, you will stop it immediately. ACE inhibitors, angiotensin receptor blockers, semaglutides, GLP, DOACs, all of these are avoided in pregnancy. In breastfeeding also, most of them you will avoid. If any of these drugs are there and the woman comes to you in the preconceptional period, you will switch them in the preconceptional period itself. Insulin and metformin, they are safe in all trimesters in pregnancy. They are safe in breastfeeding. Remember, for women, those who have type 1 diabetes, you will offer them continuous glucose monitoring. Carbimazole, safe in second and third trimester, safe in breastfeeding. Do not give in first trimester because it can cause eclampsia cutis. Warfarin, don't give in first trimester. Specifically given for women, those who have mechanical cardiac valves in pregnancy. Otherwise, warfarin is not used in pregnancy. It is safe in breastfeeding. And in the first trimester also, specifically 6 to 9 weeks, if it is given, it can cause embryopathy or it is teratogenic to the fetus. Okay. Okay. So, what are the traps that could be there in the exam? Okay. If the age is exactly 35, remember the VTE score is 0. So you will not give low molecular weight heparin, or the score, remember, it is 0. Family history of long haul flight because of leading to a DVT, 0 points for the woman. Previous VTE provoked by major surgery only because it's a score of 3. So you will give low molecular weight from 28 weeks. The score is only 3. Previous VTE, a non-surgical or estrogen related, it has a score of 4. So, sorry, let me go back. So anyone with a score of 4, you will give from booking and also you will give 6 weeks postpartum. BMI of 35 and a multiparous lady. You will not give aspirin because it is only her BMI is high. Multiparity is not a high risk factor for developing preeclampsia. BMI 35 and age is more than 40. Again, there are 2 moderate risk factors. So she qualifies to get low dose aspirin. Pregnant lady on carbimazole at 6 weeks. So switch to PTU because carbimazole not safe in the first trimester. Pregnant lady at 18 weeks on PTU, switch to carbimazole because you don't want to give PTU for a long time. It is hepatotoxic to the mother. While doing OGTT, fasting is 5.6. 2 hours is normal, but still it is GDM because even one abnormal parameter and the woman is diagnosed as GDM. Woman diagnosed with GDM, fasting sugar level is 7. For her, immediately start insulin first. Then talk about diet and exercise. Woman with post-bariatric surgery and she wants you to do GDM for her. Screening. You will avoid OGTT for her. Instead, you will do HbA1c and capillary. Okay. Remember, post-bariatric surgery, they go into dumping syndrome if you give them high levels of glucose. Any woman with a blood pressure of more than or equal to 160 by 110, and it is confirmed 15 minutes later. So this is confirmed severe hypertension. You will immediately start antihypertensives for her. First line, remember, is labetalol. Magnesium sulfate is already running and the woman gets another eclamptic seizure. So you can give another further dose of 2 grams of magnesium sulfate. You are suspecting pulmonary embolism in a woman. What is the imaging that you would order for her? What is the first thing that you would do for her? Remember, first is X-ray chest, CXR, and then see whether she has signs and symptoms of DVT. If there are signs and symptoms of DVT, do a ultrasound, compression duplex ultrasound. Okay. If that shows that there is DVT, no further imaging is required. If ultrasound is negative, then VQ scan. If X-ray chest is normal, if X-ray chest is abnormal, do CTPA. Woman with antiphospholipid syndrome and recurrent miscarriages less than 10 weeks. What are the treatment options for her? So she needs both. She needs aspirin and she needs, remember, prophylactic low molecular weight heparin. She will not need therapeutic. Therapeutic only if there is thrombosis. Then you will give therapeutic dose of low molecular weight heparin. Okay, so this is the master pearl summary. This is the same thing that we just spoke right now. I'm not going to repeat the same thing that we discussed right now. So that was all from me for today. We have finished part 1 or day 1 of maternal medicine. I know it was very exhaustive for you, but I hope it was helpful to you. And we are looking forward to getting your feedback. Okay. I'm not sure whether Dr. Samya is here or not. Dr. Samya?
Hi, Chitra. I'm right here.
Hi.
Thank you.
Yeah.
Thank you so much. I know it is exhaustive list, but I'm sure they all have loved your session. See how many hearts are coming up. Guys, thank you for attending in such large numbers. And thank you, Chitra, for all the efforts because it's not easy to go on for 3 hours. And guys, don't forget
I
to
enjoyed
follow the
it.
facts because we have got in place another 9 days. We have put the weightage, we have done everything, so it would help all of you. So don't forget to fill the feedback forms. Chitra, thank you once again, dear. Thank you.
Yeah. Thank you, Dr. Samya.
Thank
Thank you,
you.
Dr. Samya. And thank you all of you for attending. And I really hope the session was useful to all of you and good luck to you for your exams. Yeah.
Thank you.
So I think, yeah, we will stop now. Yeah.